11 publications in PubMed Journals Tuesday. And I would also like to add a few words. Sir, I consider myself very fortunate to have been one of your students and to have shared the workspace with you. And he is one of the most knowledgeable and skilled person in the room, yet always remain humble. And he has shared some of great insights and lessons, not just in anesthesia but also for a personal life and growth. So, though I have been invited as a moderator today, I see this as an opportunity to be one of the students again and sharing the stage with him. So, I consider this as a great opportunity and express my sincere gratitude to this to be invited as moderator as well as to you, sir. Thank you. I welcome you now, sir.
Thank you, Surya, for the welcome. So my topic is hemodynamic monitoring. The topic is hemodynamic monitoring during resuscitation. Okay, so I don't know how many of you have seen this image. We usually get this kind of image on World Anesthesia Day. You know, anesthetist with 8 hands doing multiple things at the same time. To praise the anesthetist for life saving and all those stuff. On the other days, this day we shared in all groups. The anesthetist watching a mobile or service or operating, relaxed. So actually both are true. The first one is what we are doing when we are doing resuscitation, and other times it's kind of relaxed. So definition, what is resuscitation? The Oxford English Dictionary service operation says it's the act of reviving someone who appears to be dead or unconscious by restoring their breathing and heart function. So this is basically CPR, right? Cardiopulmonary resuscitation. Heart function, breathing function, will bring it back. But in general, we talk about resuscitation not only when the patient is totally gone, but also before that. When they are sick, we bring them back to normal. Even that is called resuscitation. So what is the aim of resuscitation? The aim of resuscitation. So basically, we have a person, a patient who is unconscious, BP is low, they have had a cardiac arrest. So the blood is not flowing at all. So we need to push the blood from the heart to the vital organs. So circulation, ensuring circulation. And the blood which is going should be oxygenated. If it's not oxygenated, no point in having a circulation. So that's airway and breathing. So this is basically the CAB of BLS. I hope you know CAB. People usually say ABC. It was changed to CAB quite some time back. Circulation, airway and breathing of basic life support. BLS course is compulsory, I think, for all undergraduate students now, all medical undergraduate students. Might have learned a little about this. The purpose of monitoring during resuscitation. The most important thing is to assess how we are doing. if we are doing things right. If our resuscitation is inadequate, we'll see a lesser response, or we can even see the patient deteriorating. And also to guide treatment. Let's say, usually when somebody has hypertension, what do? We rush fluids, right? We rush fluids, and how much fluids to give, that can be guided by the monitors that we use. And drugs also, whether we need to use vasopressors or inodrops to increase cardiac contractility, and we will get all the information from the monitors that we use. And also to avoid and detect complications. It's not like CPR is problem free. Because of CPR itself, you can create problems. The commonest one, all of you must be knowing, is rib fractures and positive pressure ventilation causing pneumothorax and all those things. And to identify reversible causes of cardiac arrest. You must have heard of this 5H, 5T. There are certain causes which you identify in time and correct it. The resuscitation becomes so much easy. And know when to stop. Sometimes the patient can let us know, the patient can move and let us know that they are alive and awake, but usually they will just be unconscious, but the BP, heart rate and all have settled, so to let us know when to stop. So the tools and techniques, what we can use depends on where we are doing the resuscitation. A requirement for resuscitation can be outside the hospital, on the road, a person falls unconscious on the road, in hospital, and in more higher critical care locations like ICUs and OTs. So out of hospital, what do you do out of hospital? We don't have anything. Obviously, you cannot be monitoring anything, right? So what do? We need a person, not a person, we actually need 8 hands. So we call for help. We need 8 hands, not a person with 8 hands. So, more people helps. Monitoring equipment, it's only you. Only you will be monitoring the patient. Clinical assessment to assess for circulation and breathing has to be done. The various protocols, as per the various protocols. Feel for the carotid a patient who is not having circulation will be hypothermic, will be cold. You won't be able to feel the carotid pulse. When I was a student, look, listen, feel used to be mentioned in the various protocols. I think that's taken off now because when you say look, listen, and feel, people just keep looking and nothing happens. Palpate for the carotid, look at the chest movement. If you are ventilating, giving mouth to mouth breathing, look at the chest movements, feel the patient's skin, how it looks, does it look pale, does it feel cold? So that's all we can do on the road, out of hospital. In hospital there are certain advantages. One is we have a patient with no disease, so we are likely to know why the patient has arrested or why the patient became sick. So it's very easy to manage, and there are obviously trained person in hospital know what to do next. Equipment and drugs are available, and usually the event is witnessed, so the response will be quick. So the most important tool is information. We should try to find, as we are doing the resuscitation efforts, we should try to find out what was happening just before the event happened, and plus the clinical context, what problems does the patient have. For example, a known diabetic patient who has been kept NPO for some reason, surgical preparation or something, bowel disease or something like that, what we think of is hypoglycemia, right? So we check sugar is low, we give 25% dextrose, patient is fine. If you don't know this, it's going to be, you cannot be using the same BLS protocol for everybody. Keep doing chest compressions, the patient is not going to come back. A hypokalemic patient on IV potassium correction has a sudden cardiac arrest. So this would have happened because the potassium containing fluid which was being, which was going on slowly, somehow rushed. Somebody opened the IV fluid or the patient themselves opened it. The fluid is going too slowly, and that would cause VT and sudden cardiac arrest. So So now it is simple. As we do CPR, give calcium and wait for the potassium to redistribute. That's it. Just completed transfusion, patient unresponsive, likely to be transfusion reaction. So the clinical context. And obviously even in hospital, you are going to carry the clinical monitoring. Palpate for the pulse, look for the chest movement if you are ventilating. The difference in ventilating on the road and here, because we have better equipment, we might be using a mask and an ambu bag or a breathing circuit, endotracheal tube. So those options are available here. And most well-known monitor, obviously ECG. What you will see here, the first image is normal sinus rhythm. This is what we expect. Below or other rhythms, tachycardia, SVT, it's a little difficult to understand and interpret every ECG. It's not required even. What everybody should know is to identify perfusing rhythms and non-perfusing rhythms. So these are examples of non-perfusing. This is what we need to identify. The rest of the rhythms don't matter. So the picture above is ventricular tachycardia. So you basically have broad QRS complex with no other waves. And below on the left is ventricular fibrillation. No QRS complex is even, just random waves. And the other one is supposed to be flat line. This is how a systole looks like. So even in VT, you find VT and VF, generally we give a shock, defibrillation. But if there is a pulse, here also palpating the pulse is required. Even though you are looking at ECG, you have to check for the pulse to decide whether to shock or not. VF, we definitely shock. VT depends on whether the patient has a pulse or not. So this is what you need to know about monitoring ECG. And oxygen saturation. Now this is important in a way because say if the heart is beating or not, we can calculate the pulse and see. But saturation, if the saturation is low, there is no way to detect it early enough without a pulse oximeter. For the patient to show cyanosis, manifest cyanosis, the saturation is quite low, like 70-80%, and that is too low. We cannot be allowing the saturation to go that low. So pulse oximeter is a definite addition. Nowadays everybody carries, not everybody, a lot of people carry this kind of a finger probe with them. I've seen a lot of residents like carrying a stethoscope, they carry this also. This is quite useful. People use this for assessing patients also. So, what does information does it give us? It shows us how much oxygen is being carried by the blood. So we get a number, 100% saturation means all the RBCs, all the hemoglobin in the blood is carrying oxygen. So, and you get the waveforms, right? You get the waveforms, so from that you can get the heart rate. And if the heart rate is irregular, you will see that the waveforms which are coming are not regular. And if there is significant hypotension, the signal is weak, the escalator waveforms will also be small. So, and there are certain other parameters which come in certain pulse oximeter, not all of them. We can get the perfusion index and the breath variability index. Perfusion index basically shows how strong the pulse is. It's a ratio of the pulsatile component of the blood versus the static flow, the standard regular flow. So generally the value is between 1 to 5. Anything less than 1 is a low flow. PVA shows up, is an indicator of blood variability index. It's an indicator of the volume changes of the patient. In a hypovolemic patient, with the changes in intrathoracic pressure, when they breathe in, breathe out, or maybe positive pressure, and then relax, the breath waveform goes up and down. So it measures how much it is varying. So this is the information you get from pulse oximeters. There are certain problems with while doing CPR with pulse oximeter. There is too much of movement, and we might be getting a lot of artifacts. And when the blood flow is too slow during CPR, or when the BP is too low, the saturation becomes, the readings which become unreliable. So we now have low perfusion technology, Massimo and Unicor. Even when the perfusion is low, we still get a waveform. In fact, in Massimo, even if there is a flat line, we still get a saturation reading. So another problem is during resuscitation, always use 100% oxygen. So say the patient has a disease like a pneumothorax, the saturation is supposed to be low. But because we are doing 100% oxygen, the saturation decreases much later, so the diagnosis is delayed. NIBP I have put just because, for the sake of completion. NIBP is practically useless when we are doing CPR because NIBP works with oscillometric principle. We need a decent pulse. So if there is already a pulse, then there is no need to resuscitate. It means we have already done our job. NIBP is not required. So we generally to determine the improvement in perfusion, we check the pulse, carotid pulse. That's what we check. NIBP, if you are able to use NIBP, resuscitation is already done. What we have in addition in the ICU, one, the expert team is already there. And people, all the people there are already trained in resuscitation. And every possible monitoring and treatment options are available readily. So I said NIBP is not useful while doing CPR, but we can have an arterial line. There's an arterial line, we get pressure directly from the artery. So even when the BP is low, we can still get the numbers. So you get a systolic BP, you get a diastolic BP, and a mean BP. Generally, people say mean is more relevant, but in my opinion, both systolic and diastolic matter. Mean just tells us if there is hypotension or not. But with the use of systolic and diastolic BP, we can come to a conclusion as to the cause for the hypotension as well. Okay, and apart from the BP as such, arterial BP monitoring uses SPE and PP values, systolic pulse variations and pulse pressure variations. These are also, indicators of the volume status of the patient. Basically, when the intravascular volume is low, intrathoracic pressure increases. Like we are doing positive pressure ventilation, the venous return is decreased, cardiac output comes from the pulse will be smaller when the intrathoracic pressure is high. Lower the intravascular volume status, more the change. So these things can be used to guide treatment, SPV and BPV. And we don't need to analyze much about this ACV, XY waveforms, but you should know that the number, the value which we get, carries some meaning. Although they say the absolute value of CP does not tell us anything. If let's say the CP is 5 in a person, CP of 10 in another person might mean the same thing. But what matters is the trend. In a patient with CP 0, it goes up to 5. That makes a difference. From 5 to 0 makes a difference. So trend matters. So CVP monitoring gives us a guidance about the cardiac function as well as the intravascular volume status. So one thing which you should be knowing about with CVP, using CVP, we can check the response to fluid bolus. So when we are starting off resuscitation, we are not sure if the patient is euvolemic, hypovolemic. So we give a fluid bolus. Right? We are always, while doing CPR, we are always, fluid is running. We have a wide bore IV camera, fluid is running. But what if giving fluids is the wrong thing to do? Let's say, for example, cardiac failure, the patient has cardiac failure. You push fluids, the heart is going to fail. It will not be able to take the load. So we give a small bolus and see the response. Say the CVP is 0 to start with. We give a fluid bolus, we see that the CVP is not increasing much. It increases to 1 or stays at 0. It means we just give more fluids, that's what it means. But if there is a response, if it goes to 4 or 5, so it means what we are doing is appropriate, we can continue doing the same thing. If it increases to 20 suddenly, that means the heart is not able to take the load. So giving fluids is not the treatment. You need to increase the contractility of the heart. That's what is required in those patients. So it helps us to decide what treatment to be done for this patient. As an alternative, this is kind of outmoded now, but this is still useful. We use ultrasound nowadays for this purpose. Passive leg raise test is an alternative. So with fluid bolus, fluid challenge test with CVP, what we are doing is giving fluids from outside. With passive leg raise test, we are just using the fluid blood stored in the legs. So we raise the leg, the blood goes into the central circulation, it fills the volume, and now you can see the change in heart rate and BP and decide what to do next. So it's an alternative. Cardiac output monitor. So if you have arterial BP and central line, arterial BP is enough to get the cardiac output. You can get the cardiac output, you can get the stroke volume, and pulse variations also they can get. If we have CVP, we can also get other parameters like SVR. And along with saturation, you can get VO2. A lot of parameters you can get from this. But we don't have to use this as a routine. I mean, it gives us a lot of information, but to set it up and use it in a resuscitation kind of situation is impractical. So if the patient already has a cardiac monitor, we can use it. Otherwise, you don't have to use this. Now, ETCO2, this is the ultimate monitor. Now, when initially I said the aim of resuscitation is to ensure oxygen-containing blood reaches the vital organs. So, where does carbon dioxide come in? So, carbon dioxide is produced because of metabolism, which is happening in the tissues. For the tissues to be able to metabolize, blood should be going and taking oxygen. So, unless oxygen goes there, the tissue cannot produce carbon dioxide. So, at least forget oxygen, at least blood has to be flowing, even for anaerobic metabolism. And oxygen goes into the periphery, and now it has come back to the heart. Come back to the heart and back to the lungs and expand through the lungs. So the full circle is done. So you get a good ETCO2 number. In CPR situation, say more than 10 is a good number. You get a good ETCO2 waveform. It means we are doing a good job at the resuscitation. So it confirms RSC. What happens when the circulation restarts is suddenly the ETCO2 will increase. Say it was 5 or something, let's say 10. It increases to 25 or 30. A sudden drastic increase points towards return of spontaneous circulation. It also confirms adequacy of oxygenation and ventilation. Ventilation is removing carbon dioxide, oxygenation is pushing in oxygen. Confirms adequate chest compression because without adequate chest compression, the oxygen and the blood is not going to the tissues. And as prognostic value, if the ETCO2 remains low, less than 10 in spite of all our resuscitation efforts, it's unlikely that the patient is going to survive. So there are alarms. Must have seen in movies if you had seen in going to ICU, you hear constant alarms. There's a constant alarm in the background. In fact, people in ICU are used to alarms. It's like background music to them. It's useful in a way. Or I can say we cannot be constantly looking at the monitors. They are doing so much work, right? We are looking at the patient. We are doing some procedures. We cannot be looking at the monitor. So let's say the BP falls suddenly, the heart rate increases drastically. The monitor will notify us with the alarms. So that's useful, but it's also a nuisance, kind of a nuisance. When there is a constant alarm, you're trying to do some work, it keeps screeching behind your head, and it's a little irritating, we become anxious, and our performance is hampered. So we have silence alarm option, you can decide, up to what extent you need the alarms. Usually I just lower the alarm volume. I need low, but I don't want it to disturb me. Now the ultrasound echo. So this, you need the patient in ICU for this ICU or any critical care setup. So it helps us in diagnosis of certain critical conditions like pneumothorax and pulmonary embolism. And also assessment, like say hypolemia. I was talking about SPV, PPV, and platelet index as indicators of volume status or patient's response, expected response to volume. So which has made the fluid challenge obsolete. But this is making everything else obsolete. IVC compressibility. If we place ultrasound probe on the liver and compress with the probe, if the IVC is getting compressed easily, it means the volume inside the IVC is low. So we need to give fluids. The patient is likely to respond to fluids. LV volume, we do an echo, we see the LV volume is low. We get a lot of information on using ultrasound. We also ensure that we have enough manpower to do all those things. The priority is to resuscitate, not keep looking at the monitor. Apart from this, obviously the blood investigations, ABG, keep doing ABG. So often, a patient with poor perfusion is likely to have developed acidosis. So pH should be low, and to treat pH appropriately, we need to know the number so that we can correct it or not correct it depending on the situation. PCO2, PO2. Sometimes PCO2 alone is not enough. Let's say the tissues are producing carbon dioxide, but it's not reaching the lungs. For example, in pulmonary embolism or just low perfusion states, the PaCO2, the carbon dioxide in the blood might be high, but the carbon dioxide might not come out through the lungs. That's also possible. So we need PCO2 also. PO2 and lactate. Lactate is also an indicator of hypoperfusion. And electrolyte, we get electrolyte values also in ABG report. So potassium, calcium, sodium, all these abnormalities of these electrolytes might be causing problems. So we need to get these values to be able to correct it. So that's it. Use available monitors effectively. Don't worry about what is not available. I give you a lot of options. Most of the time, not everything is available. So what you have is what is best. So don't think about what if I had this, it would have been better. No, there's nothing better than what you have right in hand. So use additional monitors only when necessary. I was telling you about cardiac output, right? It is usually not required, but it is nice to have. It gives us a few additional numbers, but it's definitely not compulsory for resuscitation. So you might read a lot of newer modalities and all those stuff. It is not compulsory. What is compulsory is your presence, your ability to assess and treat the patient. So develop knowledge to interpret and respond to the information received from the monitor. So the monitor alone doesn't do anything. The person reading the monitor, taking decisions based on what you find in the monitor is what is important. Okay? Thank you.
Thank you, sir. This was an insightful lecture, especially emphasizing on clinical knowledge and clinical skills and available monitors, more so than more advanced things which may not be available. So thank you for the lecture, and the session is now open for discussion and to ask questions if any.
Thank you, sir. Now we'd like to honor our speaker, Dr. V.K. Mohan, sir, Professor, Department of Anesthesiology, JIPMER, Puducherry, by Dean of SPCPMS, Dr. C. Anandavairavel, sir.
To felicitate and honor the chairperson of this session, Dr. Subhanya Ma'am, Associate Professor, Department of Anesthesiology from Sri Venkateswara Medical College Hospital and Research Center.
Association members to the stage.
So dear students, so எத்தனை பேர் OTT students இருக்கீங்க? So we have an association in Tamil Nadu. Okay, so அங்கிருந்து உங்களை felicitate பண்றதுக்கு வந்திருக்காங்க. Give them a very big round.
Now, Mr. S. Gurunathan, General Secretary, Tamil Nadu Operation Theatre and Anesthesia Technologies Association, Hindu Mission Hospital, Chennai will be honored by our team. Now, Mr. E. Prabhu, Vice President, All India Association of Anesthesia and Operation Theatre Technologists, New Delhi, and Senior OT Technician, ESIC, Medical College and Hospital, KK Nagar, Chennai will be honored by RD. Thank you all for making your presence and honoring our event of the day.
What's the name? So we have a secretary, Madam Zavera Begum from Chennai, Chennai OT Association. So in the association, Pratik, they'll share a few words. What are the importance of this association? What they are doing for the OTAD community? And what are the benefits of becoming a member in the TN OTAD Association? Over to Zavera.
Good morning all. Thank you for this wonderful opportunity for OTAD Association for collaborating with Venkateshwara Medical College. As OTAD Association வந்து இப்போ நம்ம ஸ்டூடெண்ட்ஸாக இருக்கும்போதும் நம்ம ஒர்க் பண்ணும்போதும் இருக்கிறதுக்கும் நிறைய டிஃப்ரென்சஸ் இருக்கும். அப்போ வந்து நீங்கள் சிங்கிளாக நீங்கள் ஏதாவது நீங்கள் குரல் கொடுக்கணும்னா அது இல்லாமல் உங்களோட சப்போர்ட்டுக்காக இந்த OTAD அசோசியேஷன்ஸ் இருக்குது. நீங்கள் உங்களுக்கு என்ன டிஃபிகல்ட்டிஸ் இருந்தாலும் நம்ம எல்லாரும் சேர்ந்து அது வாய்ஸ் அப் பண்ணுறதுக்காக தான் அது இருக்குது. ஹோப் நீங்கள் மெம்பர்ஷிப்லாம் ஆகிட்டீங்கன்னா உங்களுக்கு என்ன டிஃபிகல்ட்டிஸ் இருந்தாலும் ஒர்க்கிங் ஹவர்ஸ்லேருந்து ஃபிக்ஸ்டு சேலரி அமௌண்ட்லேருந்து எல்லாத்துக்குமே இது வந்து ரொம்ப சப்போர்ட்டிவாக இருக்கும். நீங்கள் இதுக்கு மெம்பர்ஷிப் ஆனீங்கன்னா உங்களுக்கு ஃப்யூச்சர்லேருந்தும் கவர்மெண்ட் ஜாப்ஸ்லேருந்து எல்லாத்துக்குமே ரிப்பேர் பண்ணுறதுக்கு ரொம்ப ஹெல்ப்ஃபுல்லாக இருக்கும்.
Go to the next speaker.
The next speaker of the day is Dr. Ashima Aswagan, Professor, Department of Optometry, Head of Occupational Optometry Clinic, Secretary of Chennai. And ma'am is Dr. Ashima Aswagan ma'am currently heads the Occupational Optometry Services Vision Enhancement Clinic at Shankar Nitraya. She earned her PhD in Optometry from the Direct School of Optometry and BITS Tirunelveli. Along with her team, she provides preventive eye care and protective eyewear to industrial employees and unorganized sector workers. Her primary focus lies in occupational eye care of underserved workers through CSR initiatives supported by NGOs. She actively contributes to setting vision standards for various occupations and plays a pivotal role in the driver eye screening initiative of the Optometric Association of Tamil. In recognition of her community services, she received the Empowering Woman Award in 2025. She is an active researcher who has presented at numerous national and international conferences. She has received several accolades, including the Young Scientist Award, Golden Jubilee Award from the Indian Association of Occupational Health, and the Bell-In Award for Best Scientific Presentation and the Best Case Report Award for the Optometry Council of India. And I welcome you, ma'am, to this event. And I'd like to introduce the moderator of this session, Dr. M. Lokanath sir, Professor and Head, Department of Ophthalmology, Sri Venkateshwara Medical College and Research Center. I welcome you, sir.
Very good morning. First of all, I thank the Dean Dr. Ananda Vairavalu sir for inviting me for this particular conference. First I thought this is actually going to be an allied and healthcare professionals conference where optometry is one part. So usually we've been invited in the conferences which is hosted by the optometry professionals, right? So this is one congruence where we have all the allied and healthcare professionals. So it is a learning opportunity for us as well to know about what is happening in the other healthcare professionals. And I was thoroughly enjoying the yesterday's session by Dr. Suresh and Dr. From the SIMS. And today's session was also very interesting. So I feel that the students who are attending today's session will have a holistic approach about healthcare needs in the country. And in every optometry students are here? Very good. So good to have the optometry students as well. So my focus will be there, but it doesn't mean that others should not be attending the session. So my topic for today is on occupational optometry, how optometrists can integrate themselves into the eye care delivery with the industries. So optometry is a profession where it's been recognized by the National Commission of Allied and Healthcare Professionals in 2021. And from 2025 onwards, the curriculum has been released. From the next academic year, the optometry profession is done for 5 years. Very good. So it's going to be for 5 years, and it's an extensive curriculum as such, right? So as such, optometry, when we talk about, people will think about this is a profession where people check their eyes. So mainly into the primary eye care. So we are the profession where we don't get involved in the surgeries, but the other thing as detection, diagnosis, therapeutic care, mainly on the aspects of rehabilitation, it's been taken care by optometrists. There are multiple specialties in optometry, of which one specialty is about occupational optometry, where I am into. So occupational optometry is a branch where we look into the efficient and safe visual functioning of an individual at work. So what am I looking for? So if a person is working, for example, an auto driver, or car, how many of you have come in auto or car today? Can you put your hands up if you have come in auto or car? You all came by walk? Is it? You all stay here? Okay, fine. Anybody who took a cab or auto? None? So, do we all anytime realize the person's vision who's actually carrying us? Think about what is the vision of the person. Is he able to see the road properly? Have you ever thought about it? Never, right? So what happens is each occupation has different visual needs. A person who is making a jewelry has to have a very good fine near vision. Okay? A person who is driving should have a very good distance vision and also to appreciate the depth. Right? So visual needs of an individual varies with the type of occupation they are into, and occupational optometry is looking at what is the visual need of a person and whether the person is fit for that particular job or not. So this is mainly the department which is concerned. So when I talk about workplace, it is not that I'm talking about an IT industry. Okay, so now walls kulla, AC room kulla, sitting with the computers. This is not what I'm looking for in workplace. Workplace involves even industries where manufacturing sector is, where there is even a small scale industries where jewelries are made, where there are lathe workers, operators. All these also include a workplace. So when we talk about workplace, it's not just the organized sector, but also the unorganized sector. So when I talk about unorganized, these are the workforce, the majority of workforce in India. For example, a street vendor, okay, or otherwise a cobbler. So all these people come under an unorganized sector. So if you take up Pondicherry, the majority of the people are fisheries department, right? So many people are involved in fishing. So that also comes under the unorganized sector. So why are we worried about the eye health here? Because globally, if you see, there are about 2.2 billion people who are visually impaired or blind. So this, mainly if it is in the productive age group, which is the working group of 18 to say 45 to 50, then it is actually going to put a lot of pressure on the economic burden of a country. Right? So it is important that we actually have concern about these people and take care of their eye health. So there is a projection from IAPP that in another 25 years, there is going to be an increase in the visual impairment, mainly in the productive age group or the people in the workforce. When we talk about the workforce, it is not just about the vision, it is also evaluating the workplace for hazards. If you see in this place, it's not finding about fault here. Okay, so there are about almost at least about 10 people who had got slipped from that place. Have you noticed it? Yes. This is because there is no contrast here and there is no sign that there is a hazard, right? So this is a reason why people got slipped or tripped. Major issues didn't happen, it is just a near miss of an accident. If a person has fallen, then it's going to be an issue, right? So this is a hazard here. So this has to be taken care. You should have actually put a reflector or a sign that there is a chance of slip because there is actually a raise here, right? So that has to be marked and informed to people. So your brain automatically gets alerted when there is a sign of risk over there, okay? So this risk or the hazards in workplace has to be evaluated. So you might be thinking, as an optometrist, why should I be worried about it, right? So when I go to workplace, first thing what I do is a task analysis, understand about the workplace. So for example, if you go to a glass manufacturing industry, okay? So when we go in, the first step comes over there is stock, right? They keep the stock, and then the next is about manufacturing the glass unit where they have a high heat furnace. So the furnace has some colors, and then the materials required for manufacturing the glass is also put in the hot furnace, and from the furnace it comes to like a glass sheets. And then at the end of it, there is also an inspection section to see whether any bubbles or any foreign body is there in the glass. And then it is finally cut and packed into the desired sections. This is what they do it in the glass industry. As an optometrist, my role here is to see whether there is a visual demand in that particular manufacturing sector or not, and see what are the hazards the person is exposed to. Heat furnace, yes, there is a high amount of both ultraviolet and infrared radiation, so there is also a chance of heat cataract, very early cataract in those people. And then his visual inspection, he cannot be taking a chance of missing out the damage in the glasses, right? So what will happen is, if the damaged glass goes out, it is actually going to affect the industry as such. So all these put together, we call it as task analysis, understanding the hazard, understanding the demand of an application. So what do we do in occupational optometry? We have a 7-step approach. We do a task analysis, identify the battery of tests which is needed for the optometrist to evaluate for that particular occupation, do a comprehensive eye examination, match the visual demand with the visual ability, and also explain to the employers and employees about the need for eye health, provide a report to the employer, and just not stop with that, have a periodic eye examination. So this is what is a 7-step approach in occupational optometry. Alright. So how occupational optometry can involve or get involved in changing the life of an individual? So this was a small study done by us looking at eye care seeking behaviors. Okay, so we did it on unorganized sector workers who came for eye camps. Look at what is their behavior towards eye care. So most of them felt that if I wear glasses, they feel that my vision is poor, so I'm not fit for the job. So they don't wear glasses when they are there in the workplace. Okay? So if they wear glasses, they see that, oh, so you don't be there in the work. Or the opportunity of promotion and other thing is being denied for them. So this is what they assume as if an eye care is being sought properly, this would be happening to them. Okay? And other thing is, they don't go for eye examinations because of the financial constraints. So they feel that if I spend the money for it and spend the money for glasses, that could actually be spent for their family. This is what is the concern from the people who are there in the unorganized sector. So as an optometrist, what we can be doing is looking at how we could actually be collaborating with the NGOs or other agencies to support the need for eye health for the individuals in the unorganized sector. So there are multiple industries who can actually be supporting us with the CSR money to cater to the need of the under-resolved people. I'm going to give an example of a sculptor. Can you see what they're doing? The main job of sculptor is to sculpt or carve where from a stone where the precision of the statue gives them the money, right? The precision, the symmetry of the statue is what they are looking at. So there is definitely a need for visual demand here. And look at the other part, because they are sculpting from the stone, there is a high possibility of foreign body fall into their eyes. This can actually affect their eye, and what usually they do is, they just take it off by themselves. So this is what they have been doing. So what we thought is, we provide them a safety eyewear. So, but just a safety eyewear will not help them, because if you give safety eyewear and you do not give them a proper visual correction, it's not going to help them with the symmetry, right? So what we offer to them is a safety eyewear with refractive correction, so that they could see clearly and also protect their eyes from the hazard. So this way we could actually help them, the sculptors, to do their work properly and efficiently. This is another toy makers, very similar to the sculptors. We did a task analysis to understand what is the job they are doing. So we went to the workplace and looked at what are the hazards in their workplace, what is the visual demand for them. And all these things are assessed. And then, of course, there is a high foreign particles, which is like flying particles, which is there, and they can actually affect their eyes. So this definitely would need a refractive correction with the safety eyewear. So safety eyewears has to be promoted by the occupational optometrist to the occupations where the risk of flying particles or the injury to the eye is more. Looking at the drivers, how many of you think that drivers need a proper vision? Do drivers need a proper vision? Yes? Okay. So what else is needed for the drivers? Just the vision is sufficient? What else he will be looking at? He will also be looking at a side vision, right? The side vision is also important, and he has to respond to signals. So color vision is also important for the drivers. So when we are evaluating for the drivers, it is not just the vision. We also evaluate for the visual field and the color vision for the drivers. Apart from it, there are multiple other things which an optometrist should be evaluating for a driver. So looking at the depth perception, looking at glare recovery. Many of the drivers who are in the, say, in the mid-50s, they also say that there is a lot of glare because of the oncoming headlights, right? So they say that I'm not able to drive in the evening. So slowly what they do is they reduce the time of driving, okay? And the other one is they also experience difficulties in rain. So while driving in the rain, they have difficulties because of the glare or the contrast strategy is being very poor to them. It is important that we tell them about the importance of color vision in them. So actually speaking for driving, do anyone have a driving license here? Students? Yes, you all hold a driving license. Did they check the vision for you before you get the driving license? For everybody? Did they check a color vision for you? No, right? So most of you know, right? They don't check color vision. But with the signals, if you look at signals in India now, they have changed. It's not just a round signal now, you have also the directions, right? Right, left, all those directions. Innovative signals have been transformed into the signal lights now. So even the people with color vision difficulty can still drive and respond to signals because the position of the lights and also the directions has been incorporated in the signals. This is because of people with color vision deficiency are also included to get into the roads. So it is more of inclusive. So this is an initiative from the government to make the signals more denotative. Okay. So there is also another difficulty here. People with severe color vision deficiencies are denied with driving licenses. So mild to moderate, they still can drive on the road. But with commercial drivers, even a mild difficulty, you have to be taking, you cannot be taking a chance here because they are carrying a lot of passengers with them, right? So as an optometrist, when you are evaluating for drivers, look for color vision, side vision, and also the central acuity, okay? We did a road safety initiatives where actually we told the drivers about the importance of eye health and also informed them. People who had a very good vision for distance, we gave them stickers saying that my eyes are safe, okay? So it is an initiative to tell or inform the other drivers and also the other passengers saying that the driver with whom I am traveling with has very good eyes, right? So it is important that we create the awareness about eye health to the individuals. So other jobs which can be more hazardous and also more visually demanding are electrical, welding, plumbing and carpentry. So these are the jobs which has hazards. Do you agree? Electrical work your problem will come? Yes. Welding? Definitely yes. Most of the welding people used to use face shields, right? You have seen with the face shields, right? Plumbing and carpentry do have visual issues, mainly the hazards. So if you look at the factors which can cause accidents, most of the important factor is about the slippery floors or mainly the human factors, which you have to list down the factors which is causing the hazard and try possibly to eliminate those hazards or reduce the hazards. Do you all know that when you lift your weight from floor, you have to actually do not put pressure on the spine? You all know that, right? You should not be actually bend down like this and lift anything. You have to actually sit or squat and then lift the objects. So these kind of few things which can actually help their health also should be counseled by the optometrists. About the work posture, and yes, we know about the penetrating injuries which happen in different workplaces. These can also be protected just with one safety eyewear. Just a safety eyewear can actually cause a lot of, avoid these kind of accidents. Okay. Many of the ophthalmic nurses or nurses in the OTs, they actually be helping the surgeons with sutures, right? So nurses, when they come to 40 or 35 and above, they have difficulty in finding out the sutures in a very dim light. Okay? So what we thought is we could actually facilitate them with some magnifiers so that under the magnifiers, which is also illuminated, they can actually identify the sutures very well. So this is assessing the workplace of the nurses in the OTs. So what we did is give them a magnifier which could actually help them to see the labels in the bottles, right? Vials will have very small fonts, right? It's very difficult even for us to read that labels, correct? So you just need to have a pocket magnifier, so you just magnify the letters and then make the work easy. So it is easier to do a spotting and also to identify the sutures properly. So it is more time saving and more comfortable. You are going to avoid errors here. Okay, coming to the industrial eye examination. So we go to industries to do eye examinations. So this was a 20-year-old female, 26-year-old female who came for eye examination in the industry. There was no specific complaints. Can you see what is there in the optic? This? Is it normal? I think most of you are in the first year, so you may not be knowing about the disc features and things. So there is a blurred disc margin which is present for this particular individual, and we have to refer for a neuro-ophthalmic opinion, and we could see that they had some neurological issues which has to be treated. If this patient was not seen by us in the industries, she would have actually continued with it, right? So it is important that we go to industries and do the eye examination with a comprehensive one, not just start with vision examination and stop with the refraction. Do a comprehensive eye examination, which is very essential. This is another individual whose vision was 6'9" and 6'6" in the right and left eye. The intraocular pressures were well within normal limits, but look at the optic nerve head. So this is a case of glaucoma where there is loss of nerve fiber layer, which is seen here. So this patient had to be started with glaucoma treatment. Okay, but look at the age. Definitely this patient would have just, if needed, they would have just gone to a optical shop, did a refraction and just did a change of glasses. So it is important when we do an eye examination in industries, do a comprehensive examination so you can actually identify for diseases which can be visually impaired. So major ocular problems what we screen in industries are for cataract, glaucoma and diabetic retinopathy, and also usually in the CAMs, right? But have in mind that work-related injuries should also be screened, and the employees should be given awareness about the protective eyewears. Other things which you have to concentrate is about the eye strain and the musculoskeletal disorders, and give them the counseling about how to maintain their postures, tell them about the 20-20-20 rule to maintain a good eye health when working with the computers. So way forward, how do we actually incorporate occupational optometry in the practice? Is in the organized sector, choosing the right person for the right job. So if a person has color vision deficiency and you put them in a place like where color screening is important, he is not going to perform well, right? It is very simple. Put the fish in a tank to swim. Okay, you cannot ask the fish to climb the tree, right? So this is what you have to be looking at. I have to pick a right person for the right job. So this is also a responsibility of an optometrist here. And the other thing is looking at the hazards around. If possible, eliminate the hazard or otherwise reduce the hazards by using some substitutional methods. So this is a responsibility of the industries to make sure, because otherwise the industry is at risk of getting their license cancelled. As an optometrist, we can also be evaluating the workplace and we can recommend the changes which can be incorporated in the workplace. Lion is always a problem, right? Do you stand in front of the lion? No. But if you stand in front of a lion which is inside a cage, yes, but it is still a lion, right? So you just need to know about the hazard which is involved in the industries, but how the hazards can be eliminated can be looked at and recommended. Other issues which are coming up in industries are about non-communicable diseases, which should also be screened for. Look for diabetic changes, look for lifestyle changes, and also look for say patients who are experiencing mental health issues. Okay, so because workplace is a lot of stress, and if you identify any employee with any mental health issues, inform the doctors over there or inform the employer over there that the person needs some attention. Okay. So it is important that we follow all these steps, the 3 P's here: preservation, prevention and protection, and promotion. So preservation is about rightly identifying the person and do a pre-medical examination. And prevention and protection is about periodic medical examination, because few industries, like yesterday sir was mentioning about how radiologists get exposed to x-rays, right? So you do a periodic examinations to them to identify how much of exposure of the radiation is there in their body, and then advise them for rotations, right? And promotion is about the lifestyle changes, look for the lifestyle issues, and then encourage them for a good lifestyle changes. So this is spectacles which is being used by our industry worker who was actually looking at these microscopes for a long time. So many of you here in the laboratories also you'll be using microscopes, right? So microscopes should have a head with a rubber. If not, if you are using the spectacles and you are using the microscope for a longer time, it can actually get scratches onto your spectacles. So it is important that you have a rubber cap. Just advising about a rubber cap. You might be thinking, why should an optometrist be advising about a rubber cap to the industries? Just to safeguard their spectacles so that the repeated change of spectacles can be avoided by them. Okay, so if you are using microscopes, always look for the rubber cap over it so that your spectacles will not get affected. Yes, unorganized sector are a group of individuals who capture the majority of the workforce in India. So it is important that as an optometrist, as a community eye health professional, we should also be catering to their needs by going to their workplace, not just sitting inside an OPD room and waiting for them to come to you. So maximum possible conduct eye camps to these individuals, provide them with spectacles, understanding their visual demands. Okay? So it is important that we also take be as a responsible individual getting into the community eye health and integrate yourself with the NGOs. So just do not stop with the clinical examination, do a comprehensive eye examination. Raise questions from each industries or each unorganized sector where you are going for, and ask for a research question, and if possible you can even write grants from the central government of India or even the industries or even the universities. You can actually get grants and propose research for those topics, and in the community reach to them, create impact in their life. So there is also a certificate program in occupational optometry. If anybody is interested, you can take that up. Always give counseling to the individuals about the safety of eye health. That's very essential, because if they safeguard their eye health, their visual issues can also be minimized. You could see a smiling face of a farmer. I'm sure the spectacles which fit on them is not cosmetically appealing, but the work, what she does, is farming, where she actually gets hit by mud and all, right? So she says, I'm now happy because it is safeguarding her eyes. She need not actually be worried about whether any foreign particles falls on the eyes or not. Okay, so they are not worried about the cosmesis, they are worried about the safety of their eyes. So that's our team, and I thank my team for helping me with all the occupational optometry services. Thank you so much.
Thank you, Dr. Reshma Ashwin, for the wonderful lecture and also the beautiful slides. So, any doubts from the audience? Not only the optometrists, but also the other technicians or the other allied subjects. Because it always a teamwork where all of us involved in healthcare, and because recently we had nearby hospital where the technicians had injuries due to the burst of the sweet oxygen cylinder and lost his eyes. He said at the age of 22. So it's everyone's duty. Sometimes the companies or corporate insist to wear. Sometimes whenever somebody is watching, we wear the safety wears. After that, we remove it. So that should not be happen at any time. It is our individual responsibility to act as a role model in preventive healthcare, especially the eye injuries. 99% when you wear the safety measures, most of them can be prevented. At least we can reduce the harmness due to the injuries which result in permanent blindness. Just I have one question. Sometimes people come from village and ask them to wear, we have some 4 or 5 hours. So when you advise them spectacles, because of the spectacles or their work, they may not be able to link to. How do you counsel them to?
So it is important that we give them an instruction about, like, without the spectacles, what is the clarity of vision they get, and with the spectacles, how it is going to be improved. And also re-emphasize on that this is actually going to help them in the workplace and not as well, definitely a recommendation, right? So, for example, embroidery workers, if they see better only, they can actually give an embroidery which is perfect the symmetry. So we always show them the task which can actually enhance with the spectacles, so there is more of complaints from them.
So especially this is very difficult, and especially workers like farmers. So it's very difficult to explain the need for the visual, because sometimes when the snake comes, they could not be able to see. So unfortunately, when they touch it, then they got the snake bite. This is what you have to give as an example. So the importance of the wearing the protective vision as well as the visual demand for individual works. So you have to assess the need for the visual need. If it is not gets corrected, what is their dangers or what is their hazards to the eye as well as to the life also.
Right. So we also advise them with the headbands so that the fear of fall of spectacle is not there. We even tell that to the patients.
So any doubt?
Yes, sir. I'm
Yeah, please.
So, hello, ma'am. It was actually a very, very interesting talking. I'm from a very different field. I'm from humanities actually, but I found it very interesting, so congratulations for that. My question is, occupational optometry, this is like you have touched almost all the fields, like goldsmith, then you have also touched different like farmers. Now, what I have seen, I'm from northeast part of India, but I have what I think that they are not aware of their eye health. Now, who is going to raise the awareness in them? And apart from that, will these specs or the eyewears be cheaper or like free from? And who is going to do that? That is one of the concerns. Although yes. It's not a technical concern, but something
you rightly pointed out, ma'am. Creating awareness and making sure the availability of eye care services is what is essential. So mainly from the northeast and all, they feel that they don't have the time first of all to go, and then comes the financial aspects, right? So there are NGOs, mainly for the Northeast, there are NGOs who are willing to help for these underserved marginal populations. Okay? So it is rightly tapping out to the industries in those sectors and then ask them to support 2% of their CSR to the public. So that is what we are doing. We are actually looking at industries which is there in those locations. For example, we go to Kanchipuram. We look at the industries in the Kanchipuram to support the village people there. So in each village there will be, for example, in the Northeast you have the embroidery workers, right? So you cater to them first. Let them be as the ambassadors for eye health to the other population. So that is what we are doing. So we go to a group, we touch their associations. Definitely they have associations. So we go to the associations, look in the industries there and slowly market the need for eye health to every other individuals. The CSR money is being looked in for eye spectacles as well. So it is given free of cost to the individuals. Thank you.
Before you conclude, so if you are going for visiting any factories such as a chemical industries, the previous health record, like example, color vision and other things normal. Don't copy and paste the same thing in the next year examination also. Because previously it may be normal, because of the exposure to the constant to the chemicals which produce neurotoxic and resulting changes in the color vision, which can be early identified, you can shift the workplace and other things. I just want to add this message. If there is no more questions, we conclude the session. And once again, I thank for the wonderful talk. So they are one of the pioneers to bring this subspecialty, the optometry, like occupational optometry in India. I congratulate the entire team.
Thank you for thanking us. Now Dr. C. Anandavaival sir, Dean of Sri Venkateswara College of Paramedical Science, will facilitate and honor the chairperson of the session. Dr. M. Loganathan sir, Professor and Head Department of Ophthalmology of Sri Venkateswara Medical College Hospital and Research Center.
And I request Dr. Rashmi Asakam to join us. Now it's time for a short break, and I specially reminder to all that we have an international speaker after our tea break. So kindly I request everyone to reassemble as soon as possible.
Just 15 minutes break only because we are going to speak from UK and we have to adjust the timings. So come back soon within 15 minutes. Thank you.
Gracias. ஒரு இன்ட்ரெஸ்டிங் டாபிக், ஒரு இன்டர்நேஷனல் கான்ஃபரன்ஸஸில் ஸ்ரீ வெங்கடேஸ்வரா காலேஜ் ஆஃப் பேராமெடிக்கல் சயின்ஸில் வந்து அட்டன் பண்ணுறதுல ஐ எம் ஸோ ஹாப்பி. A very warm welcome to everyone. It's my privilege to moderate this important session on pacemaker technology, its uses and impact on heart health. You know, the pacemakers are among the greatest medical innovations of the 20th century, providing life-saving therapy for patients with irregular or slow heartbeats. Over the decades, technology has advanced for bulky external devices and today impact leadless pacemaker and smart pacemakers with the remote monitoring features. In this session, we will explore how these devices work, their clinical applications and their profound role in improving both the survival and quality of life. Introducing the speaker. Mr. K. Mohammed Akram is working as a cardiac technologist in the Department of Cardiac Electrophysiology and pacing in Arrhythmia Heart Failure Academy at Madras Medical Mission, Chennai. He has been actively involved in providing technical support, assisting permanent pacemaker implantation, higher-end device implant, CRT, conduction system pacing, electrophysiological study and radio frequency ablation for SVT and VT. He plays an active role in conducting annual educational programs organized by the Madras Medical Missions. He also reviews and manages the remote monitoring and device cleaning in the centers and he plays an active role as mentor for students of allied health professionals in the centers. He has worked on various academic and research projects, along that authored a book chapter and co-authorized several abstract publications in esteemed cardiac journals. We are honored to have with us Mr. Mohammed Akram, highly specialized cardiac physiologist from UK and expert in cardiology and device therapy, who has guided us through the evolving world of pacemaker technology. He will explain not only the mechanism of action but also practical benefits, recent innovations and the impact of patient healthcare outcomes. Can you start the session, sir? Can you start the session, sir? The audio was visual. Can't hear the audio, sir.
Okay, are you guys seeing my thing? Yeah, thank you. Yeah, so thank you to Mr. Gupti for your wonderful introduction. It's been an absolute privilege to be taking part in this wonderful conference organized by Sri Venkateshwara College of Paramedical Sciences. And then I'm just going to talk about basics of pacemaker, which is explained in technology, uses and impact on heart health. So I am Mohammed Akram. I'm a highly specialized cardiac physiologist working at the Royal London Hospital, St. Chester's, Wolverhampton, United Kingdom. So to make it simple, I know I'm just stopping you guys from having a tea break. So being miles away, it's an absolute privilege. To make it simple, I'll be presenting in Tamil. Pardon me if I have a mix of Tamil and English. And then please let me know if you have any questions at the end of the presentation. So pacemaker basics. If you want to understand what's the basics of pacemaker and how pacemaker works, we need to understand what cardiac conduction system works, how cardiac conduction system works. So cardiac conduction system, if you see, there is sinoatrial node, which is at the top of right atrium here, which is capable of producing an impulse of 60 to 100 beats per minute. So, ஒரு sinus rhythm அப்படின்னு சொன்னோம்னா, that is a normal rhythm that arises from the sinoatrial node. which produces 60 to 100 beats per minute. When sinoatrial node fades, there will be, AV node, and then what we call bundle of His, and then there is that branches out to right bundle, which has only one branch, where the other bundle, that is left bundle, that divides into two branches. Left bundle renda pirinju, that would be left anterior fascicle and left posterior fascicle. So if at all, if there is any disease or any degeneration of these nodal cells, that will lead to indication of pacemaker. So cardiac conduction system புரியுறது வந்து ரொம்ப important. So then you will know what a pacemaker and how pacemaker works. So how conduction system depicts on the surface ECG. So எப்படி வந்து ஒரு conduction system, whenever we talk about conduction system or pacemaker, எல்லாரும் வந்து coronary system ஓட they confuse it. So coronary system has coronary system வந்து ஒரு pumping ஒரு function இருக்கும். அதாவது whereas two major coronary arteries, right coronary artery, left coronary artery, that is the pumping function, where it's an electrical system where there is SA node, AV node, internodal pathways that conducts down to AV node, and then bundle of His divides into right bundle and left bundle. So if there is any disease in this, it's going to change how my ECG looks here. So இங்க நம்ம புரிஞ்சுக்க வேண்டிய ரெண்டு விஷயம், இது வந்து P wave. So that's my P wave, where this pinkish area, so it denotes my atrial depolarization, where this QRS, what we call, it's a big R here, that is QRS, that denotes my ventricular depolarization. And then my T wave, that denotes my relaxation of the ventricle. So a normal ECG would look like there is a P, there is a P wave, and then there is a QRS, and then there is T wave. So that looks like, actively that looks like this. There is SA node, the impulse comes down to AV node, and then the atrium is already depolarized, that conducts down to ventricle, and ventricle is depolarized, you get a QRS, and followed by there is a T wave, which denotes the ventricular relaxation. So இது வந்து ஒரு நார்மல் ஒரு 12 lead ECG, ஒரு நார்மல் சைனஸ் ரிதம் எப்படி இருக்கும் அப்படிங்கறத ப்ரீவியஸ் ஸ்லைட்ல பாத்தீங்க. So that is like a P and a QRS and a T wave. So now we need to know what is normal rhythm, some few examples of normal rhythm and abnormal rhythms. So we all know if there is a P followed by QRS and T, that's sinus rhythm. But if it is like there is a P, or P wave irukku, or QRS irukku, or T wave irukku, but this is less than 60 beats per minute, then it's going to be called sinus bradycardia, where you are going to see a P wave, QRS, T wave, but it's going to be more than 100 beats per minute. That is going to be your sinus tachycardia. This is two of those normal rhythms you see, where we call sinus rhythm or sinus bradycardia or sinus tachycardia, where disease in the sinus node itself is going to produce something called this rhythm, where you see it's fairly irregular, and then there is a long gap or a pause between this activity and then this activity. This is going to be an example of a sinus nodal dysfunction. That is sinus node வந்து இங்க disease ஆயிருக்கு, so it can't able to produce any impulse, where it's going to be what we call sinus pause or sinus arrest. Where what if my atrioventricular node is diseased, இல்லனா the impulse SA node which comes down to the AV node, if there is a block between where it travels from the atrium to the ventricle, it's going to be my atrioventricular nodal dysfunction. That's going to be looking like this. அதாவது ஒரு நம்ம நார்மல் ரிதம்ல பார்த்தோம்னா there is a P, there is a QRS, there is a T, but if you see here there is going to be a P, a QRS and a T wave, and then there is another P wave, but it's not going down, and then you are not seeing any ventricular activity here. So that blocks. அதுக்கப்புறம் திருப்பியும் ஒரு P wave இருக்கு, QRS இருக்கு, and D wave இருக்கு, and then அடுத்த ஒரு P wave இருக்கு, but it doesn't contain pump. So this is an example of atrioventricular block. So now we know what is cardiac conduction system. We know important which comprising cardiac conduction system is SA node, and there is a disease in the SA node, what we call sinus nodal dysfunction. So the example of that is sinus pause or sinus arrest, where atrioventricular node or AV block that's going to be looking like something like this. So moving on, so pacemaker 9. Pacemaker is an electronic device or artificial device that has all the power or voltage that requires to depolarize my heart. So when sinus node fails to produce impulse or atrioventricular node fails to produce impulse, அதாவது ஒரு SA node impulse produce பண்ணல, so that goes into a long gap, long pause. அப்படி இல்லைனா ஒரு AV node is diseased AV node, நம்ம வந்து ஒரு AV பார்க்குறோம். So the heart rate irregular ஆகுது. அந்த irregular ஆகக்கூடாதுங்கிறதுக்காக தான் we have artificial pacemakers, cardiac pacemakers, which has a capability of, it's a power source, where you see there is a pacemaker can that is under my collarbone here, that is going down to the heart, where you see the wires here, what we call here one of the leads in the atrium, and then another wire in the ventricle, which is capable of producing impulses, which is in turn depolarize the myocardium. So indications, we all know there are so many indications, but I am limiting my talk with these indications. என்ன இண்டிகேஷனா இருக்கலாம்? Symptomatic sinus node dysfunction, நம்ம பார்த்தோம் examples. Acquired atrioventricular block, so it could be first degree. There are like 3 types in the first degree, second degree, or third degree, or something below atrioventricular node. நம்ம bundle of his kira, there is branches, right bundle and left bundle. If there are any defects or any disorders in those bundle of right or left bundle, it's going to be somewhat termed as chronic bifascicular block. If a patient heart attack heart attack, that is what we call both myocardial infarction, and the myocardial infarction stage in acute phase, he might be having some funny rhythms. Heart rate would be like less than 30 beats per minute or 40 beats per minute with atrioventricular block. That could be also one of the indication. Or if the patient is having a major surgery or procedure, post-operative atrioventricular or aortic valve procedures or mitral procedures, they might go into funny rhythms, say what we call sinus node dysfunction or atrioventricular block. So it's always good to understand if sinus node gets disease, we know atrioventricular node, the bundle of his or right bundle or left bundle or Purkinje fibers are capable of producing impulses, but still, if the rhythm is irregular or there is a long pause or a long gap, if there is a long gap, so we need to treat with the pacemaker. So this is one of the tracing from an implantable loop recorder. There is a P here, QRS, and a T. P, QRS, T, P, QRS, T goes on, and then suddenly the patient goes into a kind of a pause or asystole, where it's like it's gone here. At least 10 seconds there is a pause here. So this is one of the indications of pacemaker, where an example of symptomatic sinus node dysfunction. So pacemaker வரதுக்கு முன்னாடி இது வந்து எங்களோட ஆஃபீஸ்ல we have this cartoon. I don't trust these newfangled or modern battery powered pacemakers, because pacemakers all started 1950s. That comes up with kind of a, so the initial pacemaker they brought was like this. Early 1950s இதுதான் pacemaker. it's a temporary pacemaker. It's a large device. Whereas it only lasts for some time. கொஞ்ச நேரத்துக்கு தான் இது லாஸ்ட் ஆகும். இத பேட்டரி சார்ஜ் பண்றதுக்கு ரொம்ப நேரம் ஆகும். But now what we have now, the modern world, the modern technology of pacemaker is this. It's a temporary pacemaker where 1950s this is the temporary pacemaker they have, and is now the polar temporary pacemaker where you can select the rate, how much it should pace. What we call rate here is 80 beats per minute, and then there is a port here. There is a 2 port that comes out here. That's going to be atrial port and then the ventricular port. So this can do a lot of things, but to keep it simple, you can select the rate here. In the rate la nama pace pannom. The patient vandu oru post MI or heart attack patient varanga, they will be having if it's a say example of right coronary artery infarct, they might be having rate of 30 or 40, less than 40 beats per minute, where we need to pace them because they need to have a regular rhythm to carry on with the procedure, where we have a temporary pacemaker. அப்போ வந்து நம்ம ஒரு wire வந்து நம்ம through the femoral vein we just put it in, and then we can select the rate here, and then we can select the output, and then we can able to pace the heart. So that is what you had seen as a temporary pacemaker. Ana when the year 1958 comes, they got this pacemaker. This is the first. இதுதான் வந்து முதல் முறையா ஒரு pacemaker. அது வந்து completely it's a permanent system that is under the clavicle or under the collarbone. And now we have modern pacemakers that can do wonders. That's going to be something like this, where I told you this is going to be the CAN, or what we call generator, that gives the power source, and then from them where you can see the leads here, that's what we call wires, insulated wires, where in the insulated wire on the heart puller where it can be connected to the what we call this part, either a header. If it is connected to this, so it can able to pace through the power supply from the CAN. So pacing world has been evolved so much. So they have been trying to hear the heart sounds. That is 1800s. Around 1950s, they showed us how pacemaker can be external pacemaker can be performed, and then 1958 this is the first pacemaker that is fitted in, and now we have modern watches. Even watches, smart watches can give us an idea of whether நம்மளோட heart rate வந்து நார்மலா இருக்கா abnormal இருக்கா இல்ல என்ன rhythm இருக்கும், இது sinus தானா, we know sinus rhythm is normal rhythm, அது sinus rhythm is it regular or is it irregular, and then we are just going to look about how modern conventional pacemakers looks like. So ஒரு pacemaker component என்னென்னலாம் இம்பார்ட்டன்ட்னா pulse generator, where this is a pulse generator, and what we call pacemaker or a battery. So this has the power source, this has the energy that stores all its energy that is capable of stimulating the heart. So in the pacemaker now it has the power supply. From there it gives the impulses through the wires, through the insulated wires, what we call leads, that delivers electrical impulses to pace the heart. So the procedure is usually carried out, like this. One of the they are going to take, the operator is going to take the axis here, under the collarbone, what we call the clavicle, just around there, where we are going to see a subclavian vein or axillary vein that goes into the heart, and then you just need to thread the wires or thread the leads. The leads are நம்ம first கொண்டு போய் heartல place பண்ணதுக்கு அப்புறம், so that's my right ventricular lead or right ventricular wire, and that's my right atrial wire. When if it is connected to this port here, it is capable of pacing the heart. So what functions the pacemaker does? Pacemaker oda important rendu function therinjirukumna adu one sensing, innொன்னு pacing. Sensing is the ability to sense the intrinsic cardiac depolarization which inhibits the pacing. அப்படினா என்ன? சென்சிங்கிறது பேஸ்மேக்கர் வந்து இப்போ நமக்கு வந்து நம்மளுடைய ஓன் ஹார்ட் ரேட் இருக்கு, அதாவது நம்மளோட ஓன் இம்பல்சஸ் இருக்கு. அந்த இம்பல்சஸை அதால டிடெக்ட் பண்ணவும் முடியும். அந்த இம்பல்சஸ் வராத நேரத்தில், அந்த இம்பல்சஸ் irregular-ஆ இருக்கிற நேரத்தில், இல்லை there is a ஒரு லாங் பாஸ் இருக்கிற சமயத்தில் where it can pace the heart by giving the stimulus. So it always sees for the basic function of a pacemaker is it always sees for sensing, its ability to sense the intrinsic activity. அப்படி இருந்தா it will not pace பண்ணாது. If there is no intrinsic activity, the next the primary function of the pacemaker is to see, say there is no intrinsic activity, I'm just going to pace here. That is the ability to pace when no intrinsic depolarization noted or no intrinsic activity noted. So pacemaker terminologies. This is something which is very important. So say நீங்க cath lab work பண்றீங்க, where you see a lot of, or where you are going to work in cath lab, அப்போ வந்து you are going to see a lot of temporary wires or temporary pacemakers. Most likely அது வந்து ஒரு wire தான் இருக்கும். That is going to be primarily in the right ventricular myocardium. This is my pacemaker, that's my right ventricular wire. And then this is going to be something like this. Whatever we had seen till now, we know there is the intrinsic rhythm or the normal rhythm looks something like this. There is a P wave, there is a QRS, there is a T wave. So we know this is நமக்கு தெரியும் இது வந்து நம்மளோட normal rhythm or normal intrinsic beat. So pacemaker என்ன பண்ணும்னா that would label this as we sense, that is what we call ventricular sense. If you see this here, that's labeled as ventricular sense. But what happens when it waits for some time? So if a pacemaker, that is like a watch, like a timer. It's just like 60 beats per minute, 60 beats per minute, or 75 beats per minute, 75 beats per minute. So it will just wait for the next beat to come in. So இப்போ இது வந்து it will start timer 75 beats per minute இருக்கும். இது பார்க்கும், இது வரலையா, so there is no intrinsic, no normal rhythm. It is just going to pace, where the pacing beat looks different, where that looks like there is a pacing spike here, where you get to appreciate this, and then there is a QRS which is very broad. So நம்ம ரெண்டு விஷயம் இதில் தெரிஞ்சிருக்கணும். If it is a single wire inside, most probably in acute setting, இல்லை ஒரு பேஸ்மேக்கர், நீங்கள் ஒரு மயோகார்டியல் இன்ஃபாக்ஷன், ஒரு ஹார்ட் அட்டாக் பேஷண்ட் வந்து நீங்கள் போஸ்ட் ப்ரொசீஜர் இல்லை டியூரிங் ப்ரொசீஜர் வந்து நம்ம pacemaker பண்றோம்னா, I had shown you earlier in a small box that goes along with this kind of a temporary wire, or this is a permanent, an example of a permanent system where we have somewhere the power supply and then the wire goes directly into the heart, where you get to see or a normal rhythm it's going to be PQRST, that is going to be sensed, the R wave is going to be sensed, and then it is going to be labeled as ventricular sense. If there is no ventricular sense, till this waits for some time, then there is going to be ventricular paced beat, which is going to be, there is a pacing spike, then it's going to be very broad. So lower rate is 75. நான் சொன்னேன் pacemaker வந்து ஒரு timer, it goes well with the timer. 75 beats per minute, it just waits for 75 beats per minute. Basic function is 75 beats per minute. In the device, we have programmed 75 beats per minute. If there is no intrinsic beat till that time, it just going to paste the heart. You see, this is from this arrow to this arrow. It's going to be, say for example, 75 beats per minute. What happens is, it just waits for another 75 beats per minute. So that usually comes along somewhere, in the arrow, the 75 beats per minute comes here. But pacemaker, it had already seen my intrinsic beat here. So what it is going to do? So it had seen my intrinsic beat here. So intrinsic activity is பார்த்துச்சு. So it is going to sense this. So we know it started with ventricular pace. Say it waited for this timer to end and it paced ventricular pace, and then it started the timer and then it went on again. But where you see in the timer there was a ventricular sense or intrinsic rhythm came in. So it's just going to sense this as ventricular sense, and also it's not going to go with this. It's just going to restart the timer. But here the timer starts again. It goes again where it paces and again it paces. So something to understand is the pacemaker has an important parameter called lower rate. Lower rate it's just a timer, just goes starts from one pace to the other. Nadula intrinsic it's just going to sense this as intrinsic, and then it's just going to start with the timer again from that intrinsic to carry on with the paced beats again. So VP is ventricular pace and V sense is ventricular sense. So one of the important to something temporarily acute setting நம்ம பார்க்க வேண்டிய ஒரு important parameter என்னன்னா, we know how intrinsic beats are sensed here like this. The sinus rhythm is sensed here, and there is the paced rhythm here where there is a pacing spike, and then there is going to be a broad QRS that if you pace in the right ventricular apex, it's going to be somewhere broad QRS you are going to see in the ECG. But what happens when the amount of power or the amount of the voltage which is necessary to capture the myocardium, ஒரு அந்த ஹார்ட்டோட மயோகார்டியத்துக்கு தேவையான அந்த வோல்டேஜை விட அதிக பவர் சப்ளை தேவைப்பட்டுச்சுன்னா, there is a chance that that your pacing beat which is captured here may not capture. So this is something where we need to be very cautious, where we need to understand when there is a loss of capture. We are programmed 75-80 beats per minute it should pace, but if you don't see this wide QRS pacing at 80 beats per minute, இந்த மாதிரி ஒரு rhythm இல்லைனா, if you just see a pacing spike here, that denotes you are giving a pacing spike, ஒரு pacing impulse வந்து அங்க இருக்கு, but the power is not enough or the voltage is not enough to capture the myocardium. Where what happened, there is a pacing spike. Okay, pacing spike it captures. As a capture you are going to see the wide QRS or a paced QRS, or else it's just going to be the pacing spike, no QRS, or pacing spike, no QRS, and then it's going to be intermittent or completely go blank. So important acute setting monitoring ECG monitoring பண்ணும்போது we are always having a look at the ECG and how normal ECG looks, whether it is sinus rhythm or whether it is normal or abnormal, or when you get to pace the patient, you need to understand if there is a pacing spike you see, or you need to see a pacing spike with a wider QRS, a big QRS like this. If not, it's going to be pacing spike, no capture, or there is nothing. It's you need to make sure you set a voltage or output at the pacemaker, whether it's temporary or permanent. Just put it very high. Say 3 volts, you just need to put it at above say 5 or 8, where you get to see a QRS like this. So that is VP is my ventricular pace, and then there is a pacing spike, but it lost my capture here. That is going to be my loss of capture. So types of pacemaker. We know pacemaker generator generator is called the power source, where all the power, all the voltage comes from that. That is what we call CAN or pacemaker or pulse generator. And then depends on what indication or what particular indication you deal with. The pacemaker can be different types. There could be single chamber pacemaker, where the lead is positioned in only one chamber of the heart. That is like primarily, single chamber pacemaker, and there is a pacemaker and there is only one wire which goes down to right ventricle. Where dual chamber, where the leads are positioned in two chambers of the heart, that is like right atrium and right ventricle. Where what we also have is called triple chamber, that is what we call biventricular pacing, or the proper name would be cardiac resynchronization therapy, what we call CRT device, where the wires are positioned in three chambers. That's going to be right atrium, right ventricle, and left ventricle. What we call it is coronary sinus. Coronary sinus, if you position the wire or the lead in coronary sinus, it is capable of capturing the left side of the heart. So that is going to synchronize your both right ventricle and left ventricle. So single chamber pacemaker, there is a pacing can here. That's going to be just under the collarbone here. And there is a pacing can. There is only one wire which goes down to the heart. So venous access, then the wire just goes down to the heart, and then we are placing the wire in the right ventricular apex. The usual position of conventional pacemakers on the right ventricular apical position. Where dual chamber pacemaker, again there is a pacemaker, there is a can, two wires. One is going to be a connection for atrial wire, where that all the way goes up and then connects to the right atrial port, and then you put a lead, that is your ventricular lead, that goes into the right ventricular apex, and the port goes connected to the right ventricular port here. What happens, what we call biventricular pacing, so where it's going to be a same kind of a can, but that has an extra port, inner port with it. That's going to be, one is going to be my atrium, and then the other one is going to be my RV lead, right atrial lead, right ventricular lead, and the other one is going to be right ventricular lead, where right ventricular lead we don't necessarily want to, we don't want to go into the arterial system to get into the LA and LV, or the venous system to go from, intra-atrial septum, you need to transeptal it to go into the left ventricle. So usually it's an arterial system which has high blood pressure in it, so we don't want to go in there. But there is an alternate route where heart or the posterior side of Athena, there is a larger vein that carries all the deoxygenated blood back to the heart, from the heart back to the heart, where all the venous blood comes through coronary sinus. And the posterior region, only if you get the wire into the LV posteriorly, where you can able to if you get deep into the coronary sinus, you are going to pace the left ventricle. So that's going to be RA and RV and L. So what are the indications for CRT pacing? அதாவது என்ன மாதிரி நேரத்துல we don't need ஒரு wire இல்ல ரெண்டு wire இல்ல, we need three wires to pace the heart, to eventually to say we know there is atriums conducting, and then there is impulses which down, left bundle, right bundle, left bundle. And then what happens if one of the bundle which is blocked completely, then and your heart's pumping function, what we call LV ejection fraction, echo LV ejection fraction less than or equal to 35%, and then one of the important bundle which has two divisions in it, that is what we call left bundle branch block. அப்படி இருந்துச்சுன்னா நம்மளோட QRS is going to be something similar to RV apical pacing, which is very wide, 150 or 160 milliseconds, and then the patient is having so much symptoms, the patient can't walk, ஒரு 10 step நடக்க முடியாது. So these are typical symptoms of heart failure patients where they benefit with the CRT or biventricular pacing with this kind of an indication. So to understand how left bundle branch block works, you need to go back again to the cardiac conduction system, where if you see there is a block in the left bundle, where if you see there is this is my cardiac conduction system. The impulse comes down from SA node, atrioventricular node, and then there is a bundle of His. And what happens after bundle of His? There is a block where you see there is a block which is down in the left bundle. Then what happens? Which is somewhat similar to the right ventricular apical pacing maridam. What happens? This is blocked here, and then the impulse all comes down to right bundle. Adukapram the impulse இப்போ இந்த ஒரு bundle தான் வந்து it has to activate the right ventricle, and then what happens? It all again goes back cell by cell போயிட்டு நம்மளுடைய left bundle இது activate பண்ணுது. So அதனால தான் the QRS is wide. நீங்க right ventricular pacingல பாத்தீங்கன்னா it's going to be the same thing. What happens? You are right ventricular apical pacing, you are putting the wire here or putting the wire in the right ventricular apex. What happens? The impulse first activates the right ventricular myocardium, and then the impulse goes from right ventricle to cell by cell, and then it captures or it conducts down to left ventricular myocardium. So that's how left bundle branch block is seen in cardiac conduction system. What happens? My left bundle branch block looks like this. It's going to be very widened QRS. That's how typically it looks like in V1. That's going to be something like W pattern in V1, and then in my lateral leads, that is V6. That's going to be something like an M pattern. And then if you see right ventricular apical pacing, it is somewhat it's going to be somewhere similar to what we had seen here. But if you see a pacing spike along with it, it's just going to be your right ventricular apical pacing. So we had seen how a normal conduction system works, and then there is going to be how a normal pacemaker, the generator, and the wires, and then how many wires. It's going to be either atrial wire, and then atrial, and then there is a right ventricular wire, and then there is going to be a left ventricular wire. It's going to be what we call single chamber pacemaker, dual chamber pacemaker, or cardiac resynchronization therapy, where that's what we call 3 wires. It's going to biventricular pace to get a narrow QRS at the end of the day to improve the pumping function of the heart. But the advanced, what we are dealing with now for past, this is in past 20 years, it's an action, what we call conduction system pacing. That's what we call physiological way of pacing, where we know there is SA node, there is AV node, His bundle. What happens? Instead of putting the wire down here in the right ventricular apex, right ventricular apical position, we know the QRS is going to be something like this or something wide like this. But if you want to achieve synchronization, you need to they have came up with you just pace in this area where the impulse comes here, comes down here, and comes down to the bundle of His, and then the His bundle, and then the left bundle, where you can get a narrow QRS by activating all these both the ventricles together. So that's what we call conduction system pacing. So whatever the QRS you had seen, that would have been wider like this. That's all right ventricular apical pacing kind of a morphology. Where if you see a conduction system pacing would look like this. So நமக்கு வந்து நார்மல் ரிதம்க்கும் ஒரு பேசிங் ரிதம்க்கும் நம்மளால அடையாளமே கண்டுபிடிக்க முடியாது. That is something like very similar to intrinsic QRS or very narrow, but only thing is you get to see pacing spike Identifying the pacing spike is very important. Whenever you see the ECG, we need to rule out எப்படின்னா அது நார்மல் ECG அப்நார்மல் ECG இல்லாமல் அதையும் தாண்டி அது பேஸ்மேக்கர் உள்ள ECG இல்லை பேஸ்மேக்கர் இல்லாத ஒரு ECGங்கிறத we need to look for pacing spikes that will give out so this is one of the conduction system pacing ECG where you get a pacing spike and more of a normal looking QRS here. My pacing lab looks like this where we have we give out all the necessary kits, introduce the sheets to get the access and then get the wires or the leads into the heart, where this is my programmer where if you want to check it, you can connect these cables at the end of the lead and then get it back and connect to this where you can see the numbers. We need to know where the numbers are all we can find before we implant the pacemaker. So groundbreaking technologies in the field of pacing. We get to see leadless pacing. Leadless pacing, which is very something in the size of a coin. It's been around for few years now, where we can able to pace the heart effectively with just something like this. You go in and then just drop it in the apical septum, where it can easily there is no nick here. There is no need of putting the pacemaker, putting the wires. There are certain indications. So indications you can just put this pacemaker in where you can leave it inside the heart where it can effectively pace the heart. Remote monitoring is one of the advanced technology. It's been there for quite a few years now. Where if you have the pacemaker ulla or patient if they have something like this in their home, அவங்க பக்கத்தில் அவங்களுடைய பெட்சைடில் இந்த மாதிரி ஒரு மானிட்டர் இருந்துச்சுன்னா it can be able capable of sending the device information directly to the hospital to us, where we can see how the numbers looks like. இங்க ஹாஸ்பிட்டல்ல இருந்து if we schedule அதாவது இந்த தேதியில we need to have some information from the device. What happens if the patient sends it or if the patient just near to the device, what happens? It automatically sends information to the website, computer website, their manufacturer website, where we can able to even before we don't want the patient to come in, patient varave thevilla, they just want to have this monitor. We can able to check the numbers if it is fine or not. அதுக்கப்புறம் ஏதாவது தேவை இருந்தா we can always call them and ask them to come to the clinic. So this is the latest technology where which is something like rice grinder, அரிசி அதையும் தாண்டி அதுக்கும் சின்னதா ஒரு pacemaker they have came up recently in America, where this is like a smallest injectable pacemaker which works on the principle of light, where you see we all daily usage we use this pacemaker, and then there are certain individuals who benefit from this pacemaker, where now the modern world is dealing with one of another pacemaker which is something like very small like this, which can over the time just this is going to be the way forward in pacing world. One of the case study which real world case study which we do in our day-to-day activity or in our day-to-day life where this is the pre-ECG. I told you this is one of the case of complete AV block or atrioventricular block, where you see the rate is pretty slow, but what we are carefully looking at is this is one of the zoomed picture of the rhythm here. You see there is a P wave, there is a P wave, and there is a P wave, but no P wave is related to the QRS here. there is no proper what we call PQRST, PQRST. This is a case of third degree or complete AV block. So இது தான் வந்து complete AV block னு சொல்லுவோம், where you need pacemaker to kick in to keep both atrium and ventricle intact. So when atrium sends down impulse, this atrium should come down to the ventricle. So what happens when you put a pacemaker in? So you are seeing all the P waves here in the arrows shown. If I put a pacemaker there, where I get to see that P wave which is conducting down, and then there is a pacing spike, QRS. This is one of the kind of a narrow looking, kind of a more of a broad and narrow looking, kind of a right ventricular apical septal position, where you get to see something like this, where there is a P wave and a QRS. That's a pacing spike that gives you this QRS, where you can see now it's all going to be P followed by QRS. That's a paced QRS, and then a T. P, QRS, and a T wave. So that's how the real paced ECG would look like in the real world. So thank you so much. So I'd like to thank you, the organizing team, for giving me this opportunity to present at this wonderful conference. And then I'd like to thank Ms. Glory, who is my wonderful senior, who had asked me to present at this wonderful conference. Thank you so much.
Any questions? எல்லாரும் அண்டர்ஸ்டாண்ட் பண்ணிட்டீங்களா? ஏதாவது கொஷின்ஸ் இருக்கும்ல? யூகேலேருந்து ஒருத்தர் பேசியிருக்காரு, பியூட்டிஃபுல்லாக பண்ணியிருக்காரு, தமிழ் அண்ட் இங்கிலீஷில் டாப் டு பாட்டம் வரைக்கும் சொல்லியிருக்காரு. Any questions? It's a wonderful opportunity to you interact with him. எல்லாருக்கும் ஒரு டவுட்ஸ் இருக்கும், நான் என்ன கேட்கறது, என்ன போகிறது அப்படின்னு.
Good morning everyone. I am a lecturer from ICON Nursing Department. Usually we send the patient for MRI. If the patient has a pacemaker, we cannot send them for MRI. What is the precautions to be done, sir?
So am I audible there?
Yes, sir.
So if a patient has an MRI, if a patient wants to go to MRI, if a patient MRI போணும்னா இப்போ என்னென்னா பேஸ்மேக்கர் மாடர்ன் பேஸ்மேக்கர்ஸ் இருக்கோ அதெல்லாம் வந்து டெஃபினட்டாக வந்து MRI compatible. So they can go to MRI. But what happens? We need to anyway check. இங்கே என்ன நடக்கும்னா MRI போகிறாங்கன்னா the MRI department will send us the information about the pacemaker, about the patient. And then நாங்கள் என்ன பண்ணுவோம்னா we see those details, and then to see whether it is an advanced made device which is already MRI compatible. ஏன்னா இப்போ வர டிவைஸ் எல்லாமே mostly MRI compatible, and then we sign a form saying okay this is MRI compatible. And then நாங்கள் அதோட நம்ம வேலை முடியாது. What we need to do, we just need to go to the MRI when the patient comes to MRI. நம்ம MRI patient MRI வரும்போது we'll go there, and then we'll check the device, and then எல்லா pacemakerலையும் there is an MRI mode or MRI compatibility mode. You just need to program it on, and then send the patient to the MRI scan, because MRI la varakudi and the magnetic interference on that can inhibit, or when I was talking about the pacing or sensing, அந்த MRI la varakudi and the magnetic interference நம்மளுடைய பேஸ்மேக்கரை inhibit பண்ணிடக்கூடாது. அந்த பண்ணிடக்கூடாதுங்கிறதுக்காக you put it into a certain mode. You see whether the patient is having a good intrinsic or the patient is pacing all the time. Depending on that, you program into a particular mode, MRI mode. அப்படி போட்டு நம்ம we observe the patient, so the patient doesn't get into any kind of ஒரு asystole or pause. இதெல்லாம் வராம நம்ம இங்க பார்த்துக்கணும். There are certain conditions to say whether it is MRI compatible or not. All the recent advanced pacemakers are MRI compatible, like the CAM or the pulse generator. But what happens, the wire which they take down to the heart, it has to be the same manufacturer. Say, all the world has all major manufacturers. If a company named Boston produce that pacemaker, the wires which goes down, they should have Boston wires. Then only we say it's completely MRI compatible. Pacemaker implant, it should be at 6 weeks. It has to be more than 6 weeks before the patient goes to MRI. Then only that's MRI compatible. And then the wire parameters, what I told, is the power needed to capture the heart, which is like what we call it as threshold. If the threshold has to be in appropriate, good numbers, that is less than 2 volts, then only we say it's MRI compatible. Hope that answers your question. If not, you can ask me again if there is any questions.
Are you happy, madam? See, what happened, the pacemaker battery duration is only for limited. It's for 7 years or 8 years.
Yeah.
And 7 years or 8 years after that, they want to change the pulse generator, PG. Appadikku enna பண்ணுவாங்கன்னா whether the pacemaker is an MRI compatible irunduchina, the lead is same manufacturer, it's too good. If you want to change the company from Medtronic to Boston or something about that time you should confirm whether the lead is also a MRI compatible lead. Are you correct, sir? Are you okay?
Yeah.
Any questions?
So that's what it.
Any questions?
So,
everybody's are clear, happy. Want to close it?
Thank you, sir. Now, the speaker of the session, Mr. K.P. Mohammed Akhtar.
Yeah, I want to close the session. To summarize, pacemaker represents a triumph of biomedical engineering and clinical medicines for restoring normal heartbeat to enabling patients to lead health, active lives, and the impact of remarkable now advances in miniaturization, wireless technology, and AI integrations will only make them safer and more effective in the future. On behalf of the organizing team, I sincerely thank our dean, Professor Dr. Anand Vairavel, his glorious assistant professor of cardiology, cardiac technology, and the team members, and our distinguished speaker for the enlightening sessions, and the audience for your active participations. Thank you.
Thank you, sir. Now, the speaker of the session, Mr. K.P. Mohammed Akhtar, cardiac physiologist, will be honored by Dean of SCCTMS, Dr. C. Anand Vairavel. Thank you. And the chairperson of the session, Mr. Kasiraj Bhuvadi sir, technical head, cardiac science, Vinayaga Mission Super Specialty Hospital, Puducherry, will be honored by the Dean of SCCTMS, Dr. C. Anand Vairavel. Thank you, sir.
So dear students, so are you ready for an exciting, another exciting program? practical is going to cover all the disciplines. May it be an MIT or MRIT or OTAT, dialysis, any professionals. HP it's called, allied health professionals. So what are you going to do after your graduate? What's the plan? Any two plans. Either one or go for the post-graduation. Plan A or plan B? No, plan C, get married. Function correcta solta hai aur issue. That happens to everyone. That's the saying. Okay. Everyone has to get married. Why? Happiness is not the only thing in life. Okay, so we have got an exciting speaker from Bangalore. Okay, he is a much highly accomplished professional in the field of dialysis technology with extensive academic and clinical experience both in India and abroad. He has served as an assistant professor in many colleges, but now he is a certified kidney health coach, USA, and registered dialysis technologist under IIT India. So what he is doing and how he is going to help all the other professionals? He is noted for his own company, about which he himself will introduce, and is giving coaching for all the type of entrance examinations that is being held in different countries for the allied health professionals to get an employment there. Okay, so very important speech is going to give. If you want to relax, there is a live telecast going on at the parallel session. You can go to the hall. Why? Because in the listen of the other 30 of our nursing students have come. They are waiting patiently in that live telecast hall. They want to get employed abroad. They want to know what is going on. So, if any volunteers are there, if you want to relax, you can go there and I will bring them here. 30 students are waiting there in the live telecast. So, such an important talk we are going to give. And before that, our OTAT secretary has given an introduction about the membership to become for the OTAT students. The counter will be put up in the reception. So, Yara membership it's going to be a discounted price only. You can become member. And organization, field membership. Anyway, NCHP has come. NCHP stands for National Commission for Allied and Healthcare Professionals. It will take some more time to establish throughout India. Meanwhile, for state association member registration number abroad it's always to become a member. So as an MLT, I become member of some other organizations concerned with MLS. Okay, and one organization or membership, of course, national membership, it will take some time. Meanwhile, it's better to become a membership in the state program. So the count will be there till the afternoon or even after afternoon, but before that you can enroll it. Okay, without wasting much my time and much of the speaker's time, for 3 years back when I went to a dialysis conference in Kutipuram, there I met a young and dynamic person. At that time I didn't know that he is going to become a national figure. Okay, so let us welcome Akash on stage, please. Big round of applause.
So, corrected all of respected dignitaries, dean, principals, HOD, faculty members, and all my dear students, very good afternoon. Thank you. So, how are you people, sir? Everything? So happy. I was very happy to see such a huge people's crowd under a single roof. And I was very happy and excited to deliver my speech as well as to clear sessions. Are you enjoying? Enjoyment cultures afternoon. No worries. We will work on it. At the same time, without wasting any time, we will move on to the session. I'm just going to discuss about the topic how you can able to step up your career after your UG, PG, and whatever, right? Right? Okay, fine. I'm not going to deliver a speech on that. I'm just going to talk to people. எல்லாருக்கும் பேச பிடிக்குமா? Yes, okay. I see that many people from different states are being here, different departments here. So I hope English is very comfortable for you peoples. Tamil பேசலாம் தமிழ்ல, மலையாளம் மலையாளம், தெலுங்குனா தெலுங்கு. அல்டா உண்டோ? சரி. Okay, we will mix with every languages, not an issue. Right. So, without wasting the time, we'll get into the session. Shall we? Shall we? Okay, that's great. So, thank you for the warm introduction, Dr. Anand Vaival sir. Such a charming person I have ever seen in my life. So, thank you for this honor, sir. Thank you for being and thank you for having me here to, Sri Venkateshwara Medical College Hospitals and allied professionals, especially. Right? So, point up, yeah. So, without wasting our time, we'll have some conversation actually. What all doing your first year? Can you please raise your hands up? Okay, good. Second years? More. Third years? Quite good. Fourth year, internship? Okay. Working professionals? Working professionals. Wow, very nice. Technologists and technicians. Wow, very nice. Super. Great. Okay. So, first and foremost thing, I'll get into the topic. Just have a small interaction with the peoples. Okay. So, what are departments are being here? MLT, can you please raise your hands? Lab technology. Okay, good. Second, ideology, yeah, MIT, imaging technology. Okay, good. Dialysis? Not dialysis now. So, and trauma care management, accident and emergency. You're there. Okay, fine. There's some surprises there waiting for you people. Trauma care, I will express in the last of the session. Okay, and in a department, must physician assistant. Okay, OTAT. More. High number. Any other miss? Cardiac care, yes please. Above. Lady number 1, cardiology. Good. Good. That's sweet. Okay. I hope that you people are refreshed and get enthusiastic. Yes? Good. I'll introduce myself. This is Akash, founder and director of Gen Academy and Global Educational Network. Talking about myself, I am from a background of nephrology and dialysis technology and transplant medicine. I was posted in Savitha Medical College Hospitals. I was born in Kerala, where my life starts, where my career starts. Then I was working in Nairobi under American LLC, 2 years. And I get back to India. I start my own institution. I am training all the people from India as well as in other countries also as well. So what we are exactly doing in a sense, many people are having some interest to being part of abroad. For example, last speaker, Mr. Mohammed Surface Nama Subaba, you will get inspired. Hey, I had to go to UK. One day, I just want to be like this. I also want to become a speaker, as an international speaker. Like this, you people are having some wishes. Yes or no? No. No means I went up, no issues. Who are having a wish to work in abroad? Avaldana. The way Kerala was now, okay, that's a good number, quite impressive. And sirs, one of the nursing students are willing to partner, 30 plus people are being here. I was literally honored to have this word actually. So other departments, they are enthusiastic seeing the title and they're getting into the presentation. In a sense, I was very happy. For them also, I have a small surprise. I will tell you in the last. Okay, so without wasting our time, my topic, you can able to see the career opportunity in overseas. Things to start before you start. Things to do before you start. Okay. exceed your knowledge, extend your field. First and foremost thing, if you want to exceed some other place of lessons, you have to get engaged in knowledge, then you can able to proceed forward. So this is a brand, Gen Academy. So we are running socially in different places, states in Tamil Nadu. One is in India. One is in Kerala. Another one is in Hyderabad. So we are having offices there. We are doing all those calls up. According to that, I will just talk to you later. And what is our vision? If that's something we are starting lessons, we should have some visions, right? So according to my vision and my organization's vision is to get a better career supports for allied healthcare professionals, not only for allied but also for entire healthcare professionals. And I hope that you people are being part of global community, global cardiology network, global dialysis, global WhatsApp communities. Ilya? No problem. Fine, I will share that also as well. Okay, so this is a portal. We have started before 8 years. We started with a WhatsApp community registered under central government, IIT, IMBA, all those applications. And in that we are having nearly 90,000 plus healthcare professionals all over the world. We are running a network in 18 different countries, including US and UK, and all the Gulf countries also as well. We are having an official MOU with 18 hospitals only in Gulf countries. That's our ground setup. With that, we are proceeding toward Prometric and all those stuff also as well. So, I just want to talk to you people. What you're going to do after your UG? Marriage? No. Randa. Okay, what are you going to do after your UG? Anyone? I just want to have an interaction with the peoples. Please, the discussion class. Now, we are going to interact each other. Please, don't need to worry about shy. In the language, there is no language barrier for me. We can able to proceed whatever it is. Don't think that what Ranjit will think, what Akash will think of them. Right? Please. Yeah, he's asking. What are you going to do? Anyone? Sorry? PG. Okay, very nice. After PG, what are you going to do? After PhD, what are you going to do? Marriage. Wow. Now, our people's, we are something special actually. We are doing MSc, BSc, PhD, only to put in your marriage invitation. Fine, chalo, whatever it is. The peoples, other peoples who are going to masters, after masters, they're saying that as a PhD, they're going to work as an assistant professor, like this being teaching faculty field also as well, right? And but about you peoples who are going to work in clinical. Anyone is having to work in a clinical base? Yeah, many peoples. Okay, fine. What are you going to work as an technologist of which field? Sorry? Okay, what department of Polama? Okay, first anesthesia technology. Okay, fine. You're going to work in an anesthesia technologist. Okay, so what's the next plan? How many years you're going to work as an anesthesia technologist? 2 years. After that? Chalo, fine. So here I'm going to talk about how you can able to extend your field. You can able to extend your career to overseas. Okay. A small question here. So what is called Prometric examinations? What is called Prometric? What is called Prometric? Okay, I need a volunteer who want to go to abroad. One volunteer is going. Please give a mic. Mic and pass on, please. Okay, very nice. Thank you for volunteering. I'm here. Anyone who wishes to go to abroad, just casual or no issues. The last row guy, you said Ram? Anyone? You. Well, Michael never faced an online shoot. Okay, okay, this. Please pronounce it, no problem. Do a regular session, discussion session. It's gonna be please, one person standing up. Yeah. In the department here. Please a little faster. Hello. Hi. Hi, Pa. How are you? Pa, you know that. Okay. What's your good name, Pa? Sorry? Vetri. Wow. Namely winning. Good. Where are you from, Vetri? Chennai, Chennai, Alpanam. Ananagar. Okay, which department you are from? You are a student or intern? Sorry? That is same data. Okay, so what do you pursue now actually? Whether you are a technologist or as a student? Student தானீங்க? Third year படிக்கிறீங்க. Wow. So இப்போ எந்த காலேஜ்ல படிக்கிறீங்க? Sorry? என்னப்பா? Okay, good, nice. Okay, BSc படிச்சிருக்கீங்க இல்லையா? So what's your planning actually? Abroad போகணும் plan பண்றீங்க. You're planning to go to abroad, isn't it? Okay, but ஏதாச்சும் தெரியுமா உங்களுக்கு abroad போகணும்னா what are the things you have to do before? Do you have any knowledge about it? No, sir. No. Okay, fine. So எந்த country போகணும்னு ஆசைப்படுறீங்க? Which country you want to go? UK. Okay, fine. UK is your first preference, இல்லையா? Okay, fine. So first and foremost thing I'll talk about it. Okay, yeah. So Vetri said that you want to go to UK, you want to work as a technologist. Okay. So first and foremost thing, if anyone wants to work in abroad or any other overseas country, in India, you should have minimum 2 years of experience. Whether it is MIT, radiology or MLT, whatever it is, you should have how many years of experience? 2 years of experience after your BSc. After your UG or PG, you need 2 years of experience as a minimum. First category. Second category, about your registrations. For example, Mr. Vetri Solidam actually is saying that you're going to work in around US. There is something exams you have to roll out. You have to enroll some examinations. One. And second thing is you have to register in India. You people are having a council. As per Sir said, NCHS is going to get it up, but little delayed because of some procedures and protocols. But state registration will be there. For example, for dialysis, they are having an IADT, Indian Association of Dialysis Technologists. In that, you have to register and you have to work for 2 years after your registration. Okay. Concept is 2 years BSc முடிச்சிருக்கணும் or diploma முடிச்சிருக்கணும். Well-known, established UGC affiliated university முடிச்சிருக்கணும். People who are completed with 1 year of experience, 1 year's BSc course, they won't consider in any of our country. Okay. Second thing is you should have registered. State or national commissions, national boards, they have to register their name as a membership. Okay. After the membership, 2 years of experience is very, very, very mandatory. After that, you can able to start all the preliminary sessions like your exam preparation, your data flow, and all your chromatic preparations and all those stuffs. Right? Are you clear with that? Any other doubts? Or else you want to tell in Malayalam or something? Malayalam? Malayalam? Manda? Vena? Hey, yes or no? Okay, fine. So first and foremost thing, we BSc കഴിഞ്ഞിട്ട് 2 കൊല്ലത്തെ എക്സ്പീരിയൻസ് മുന്നോട്ട് തന്നെ ചെയ്യണം കേട്ടോ. And after that, IADT or else any other council registration ചെയ്തിരിക്കണം. Okay. And all those steps at the end of the session, you have to register in all those paramedical board as well as your data flow എല്ലാം കൂടി ചെയ്തിരിക്കണം. ചെയ്ത ശേഷമാണ് നമ്മുടെ എക്സാമിനേഷനുകളിൽ പോകാൻ കഴിയും. ഓക്കെ, ഇതാണ് അതിൻ്റെ ഒരു 1 line സ്റ്റോറി എന്ന് പറയാം. ഓക്കെ, മലയാളം പഠിച്ചത് മലപ്പുറത്തിലാണ്, കുറച്ച് which Anurandam. So, yeah. So here we have mentioned here clearly about the paramedical and the nursing pursuers are actually. So for the nursing, I mean different students, different departments having different examinations. For example, allied is entirely different, and for nursing is entirely different. But it's all comes under the same council, but also it will be in a different phases, right? And talking about the UK and US, as per he said, like if you want to go to US, UK, or any other Middle Eastern or the Western countries, you have to crack your IELTS, OET, PTA. Like some few exams, English linguistic exams is there. It's not so mandatory for the peoples who are from medical syllabus. Matriculation syllabus. If you are from matriculation and if you are from English medium syllabus, there is not at all mandatory, but certain conditions is there. Conditions apply. It's not mandatory, but conditions apply. Okay, and especially for nursing, if they want to go in Middle Eastern or the Western countries, they have to crack some few examinations. They can't able to directly go to US or UK and all. What the main thing is, if you are trying to be in part of UK or US or Middle Eastern countries, there is some few conditions is there. Okay, people should have 2 years to 5 years of experience, and they have to try a lot for immigrations, and all those interviews will be done in online. Secondary interview will be there, so it's a long stretch process actually. Getting my point. But if you are in an international board, which means that, for example, from India to going to America and Australia is great deal. It's super awesome, but still everyone can't able to enjoy the spice, right? They can able to go to any other Maldives, Gulf countries. If you're having for example, India 5 years experience abroad 1 year experience, there's entirely total differences there. So if you're getting an experience in abroad or overseas for 1 year or 2 years, more than enough. You can able to apply easily. You can able to switch or jump to Middle Eastern or Western countries. You can able to settle up there, right? So this is beneficial points. I just want to talk to you people regarding that. Okay, and so as I mentioned here, different countries having different examinations, right? So what is prometric exam? Do you people know about prometric exam? No idea, right? So as per I said, whatever country you want to go, you have to crack that country's sole examination, which means that they are having a ministries, they are having a separate board is there. In that, you have to crack the examinations, you have to get the license here. Right? This is a first and preliminary concept what I want to talk to you peoples. Okay. So this is called prometric examination. Prometric examinations mostly is a licensing examinations which is conducted in Gulf countries. I'm just going to talk about Gulf countries because of the different sources and different lines will be there. So once we crack out with the prometric examinations in Gulf countries, next we'll move on to Middle Eastern country. Is it okay for you? Is it okay? Okay. Name some few Gulf countries which you want to work. Dubai. Why Dubai? Sorry? Higher salary கொடுப்பாங்களா? Okay, fine, good. என்னப்பா? Tax இல்லையா? I didn't get you. சொல்லுங்க, கொஞ்சம் ஜாலியாக பேசலாம். என்னப்பா? அயர்லாந்து போகணுமா? நீங்க அயர்லாந்து போகணும் ஆசைப்படுறீங்களா? Okay, fine. Sorry? Kuwait. Okay, Ireland is not a Gulf country, it's a Middle Eastern Western country actually. Okay. Any other Gulf countries which you know? Andhra Pradesh. Nepal? Gulf countries. Okay, any other? Sorry? Saudi Arabia. Wow, good. Oman, Qatar, Bahrain, Sharjah, Ajman, many countries is there. Listen carefully. Listen. Whatever country if you want to go, we have to write the examination for their own ministry. For example, one first person says Dubai. Dubai born abhinata, you have to crack DHA exam, Dubai Health Authority. It's called as DHA, Dubai Health Authority. இருக்கிற எக்ஸாம்ஸ்லேயே easily we can able to clear அப்படின்னு சொன்னா Dubai Health Authority சரியா. அண்ட் செகண்ட் ப்ரொமேட்டர் இருக்கு, ப்ரொமேட்டர் லிட்டில் டஃப். அண்ட் அதுக்கப்புறம் அபுதாபி ஹார்ட்னு சொல்லுவாங்க, HAAD அப்படின்னு சொல்லுவாங்க. பேருக்கு ஏற்ற மாதிரி கொஞ்சம் ஹார்டாக தான் இருக்கும் எக்ஸாம்ஸ். இட்ஸ் வெரி வெரி டஃபஸ்ட் எக்ஸாம்ஸ் ஆஃப் ஆல் Gulf country use examinations. And yeah, I clearly mentioned here for people's Gulf is especially for, you know, here I mentioned here, Gulf is especially for all the GCC countries, UAE, Qatar, and all. We are having prometric examinations. And second, come to down the line, we are having nursing people or any of the healthcare professionals. They want to go to US, UK, Canada, Australia, wherever it is. They have to crack all those examinations which is mentioned here. We are having the US medical licensing examinations, USMLE, and HARD is for Abu Dhabi, and bond exam especially for nephrologists and renal nursing students. I mean, renal nursing people who are pursuing it. Okay, so the thing is, people who want to work as a renal therapist, for example, many people from the dialysis department, they will do that. Go to LinkedIn, dialysis vacancy, dialysis technologies vacancy in US, in UK, this, that, everything they will type. But the thing is, sad part is, what you are doing is great, I will appreciate it. Once upon a time, I also been that, I was doing all those stuffs and all. But after some maturation, I just came to know, check because US and UK are destination like renal therapist. Okay, yeah. So, renal therapist or renal physicians like this only, they're giving a title for us actually. So, if you're typing as a dialysis technician, technology in the sense, it comes under biomedical. Okay, so this is what I wanna tell you peoples. And yeah, we're having an AMC, Australian Medical Council. Wherever you wanna go, you have to get into the examinations, you have to crack, you have to pass, you have to eligible, you have to get certified with that, right? And yeah. So who and all can go? Professional categories in healthcare professionals. First comes with the physicians and specialists, nephrologists and the MD, DM, MS. They are considered as physicians and general practitioner and as well as a specialist. And second is this MDS, BDS, dentist. All those same criteria. 2 years, specialist and 3 years of experience is mandatory, right? And talking to the next, nurse and midwives, and they are also the same. In some countries, nursing people's having 1 year of experience. For example, German, Australia, and they have without nursing people can able to go with 1 year of experience. But generally, going with the 2 years of experience is very, very, very good for them actually. And after registration, 2 years of experience is very mandatory. It's good to go with a good package, right? And third number, allied healthcare professionals. Okay, there are the many streams is there. One by one we will talk about it, we will discuss about it. Okay, and trauma care and accident management, that is a private sector in Dubai Council. For example, trauma care and management peoples, we are included in allied here, but they are comes under emergency force. With that, emergency medical force. This comes under DCAS, Dubai Corporation of Ambulatory Service. They have to write that exam. They are not comes under DHA. Right? Is it clear? Okay. For example, yeah, as per I said that what are the registrations you want for different countries. For UK, SCPC registrations and Ireland core registration, and for UAE, MOH, DHA, HARD, DHCC and DOH, many exams is there. And Australia, they are having an Australia preliminary licensing exams, and Canada, Cambridge. This is not a council registration. For example, how we are having a medical council, how India is having a medical council. Likewise, they are having a medical council in that. They can able to register under that first. Okay, but in the few streams are having examinations. So once they clear the examination, they are satisfied. Okay, and talking about the Qatar and education qualifications, here we have in Qatar, New Zealand, Bahrain, Oman, Saudi. They are the one they have to register under QCPHI, and all those preliminary licenses which they have to go with that. And Bahrain is having a national integration board, different streams where they want to work, they have to register under it. Okay, and talking about the professionals, who and all can able to be in part of it. This all the professionals can able to work. Another
Here, who and all is here, everyone can able to up us with 2025. Yeah, 2025, they launched big news for all the allied healthcare professionals. They're going to recruit, like what and all is not there. Physician assistant they also can able to go. Neurotechnologist they also can able to go. What are the technologies which is underlying? For example, diabetology, for no one is having a diabetic technology is there in the course. They also can able to go. And what else? Like many other courses that they missed. Neuroelectrophysiology and physician assistants. All those people can able to work in abroad, in the Gulf countries especially. Okay. And move on to the next slide. Like preparatory examination. Now we talked about preparatory examination, so supersonic preparatory exam. But what is the criteria? How to go with that? Like we will talk something about it also. Is that my voice clear? Okay, fine. So we'll get the type of exam for you, Angela. What type of exams you want to prefer? Kaila book kuduthu, paper pen kuduthu. Okay. Abhya? Okay. So what we like, in the COVID time, we are having a computer-based test, CPT in Silvanga. We'll go with the CPT examinations. For example, here they can able to having a screen, a camera on. We have to answer all those stuffs and everything over there, right? So it's also a computer-based examination. So the exam is abroad, Gulf, Dubai, no need. Chennai center, Bangalore having center, Hyderabad having center, Trivandrum, Calicut is having center. Moreover, all the metropolitan cities having centers. Okay. Talking about the examination part. In college life, how many are also no problem. It will be a back paper. Whenever you get bored, you can able to learn, you can able to clear it up. Isn't it? Yes or no? Yes or no? Yes. Okay. So this is like, it's gonna be a very, very, very limited numbers there. Ellarkum 3 chance. How much? Only 3 chances they are having. Okay. So once if you're not cleared in all the 3 chances, you can't able to eligible to go to abroad. You can't able to write the examinations also as well. If you want to write in the sense, you have to wait for 1.5 years. After that, you have to pay some penalty amount of 1.5 lakh something. Then you can able to get only one last chance. It's a payable, right? This is what the examination criteria will be. Moreover, every exam is having 3 attempts only actually. Okay. If you people are clear in your first attempt, it's well good. Easily you can able to recruit it up. Okay. This is a class of examinations what you are. And different, as I told earlier, different countries having different examination. At the meanwhile, they are having a different strategy also. For example, some countries is having a computer-based test. Some countries having oral interview. Oral interviews, for example, there will be 4 panel members will be there. They will ask some questions. You have to satisfy them with their answers. This is the concept. For example, what are the countries having this is computer-based oral interview since Abu Dhabi. Abu Dhabi is the first and number 1. It's very, very hard also as well. Abu Dhabi is having an oral-based interview test. If you're satisfied, 30 to 40 minutes connect on one. If you're satisfied with your answers, you're registered, you're passed, your certificate will be generated in your mail and PDF. You can able to it out. Okay, talking about the oral-based examinations, we're having an MCQ type questions. MCQs. 1 for A, 2 for B, chance okay, computer-based test. Solo compartments. You have to go to the center. Particular suited cabinet in that you have to attend the questions. You have 3 hours of duration. How many hours? 3 hours with 150 MCQs. 150 MCQs will be there. We have to get 55%. How much? 50 to 55% you have to score the MCQs. After score another 50% okay, if you score before 55%, you are eligible, you are registered under DHA or Saudi, whatever it is. This is a concept what I want to share you people. Okay. And these are two types of tests there. One computer based, another one oral based. But talking about the trauma care management, trauma care and accident care, emergency department, EMS, paramedics, advanced paramedics. Anyone? No one is there? Accident emergency, okay, very nice. Which year for you? First year, okay. To be very honest, there was a small surprise for trauma care management. At present, in this time, I was thinking why I didn't take trauma care management. I'm very sorry to say, what to say. That is the one which is feeding me my names and fames, everything because of that is the department, but still, and the human tendency for that. Likewise, now I'm thinking the trauma care management. You know what? You know how much is the international salary package? Any guesses? Any guesses for trauma care management international salary package? Any guesses? Oru kodiya. Any guesses? Sorry? 1.5 lakhs kadiyadu. 1.85 lakhs. Merely starting salary. Aதாவது or BSc முடிச்சிட்டு 2 years of experience, trauma care department, people can able to in the local, for example India or 2 years work பண்ணிட்டு if they go for they have to crack the examination, DCAS exam சொல்லுவாங்க, DCAS சொல்லுவாங்க. If they crack the examination, your salary, your worth is 1.85 lakhs monthly with free food, free accommodation, free transportation. The human in our life, come on, they are very deserved. And my friends, வேற பத்தி பேசலாம், எப்படி இருக்கும் பேசலாம். My friend இருக்காங்க, she is from Thrissur. Her name is Kavya. She is working as an DCAS emergency paramedical work பண்றாங்க. They are having a separate force. For example, the army force, navy force இருக்கும் இல்லையா, அதே மாதிரி ambulatory force and separate ambulatory force will be there. They are having an for example Dubai or Chennai or state naka Chennai is a city, right? Postings போடுவாங்க actually. Okay, the postings will be in an rotating manner. Recent the IPL match பாத்தீங்களா IPL match ஈசாலா கப் நம்மதே சொல்லிட்டு RCB வின் பண்ணுச்சு இல்லையா, அந்த கல்ஃப்லாம் மேட்ச் நடக்கும் இல்லையா, அங்கெல்லாம் they having emergency team. For example, இப்போ முக்கியமான அசெம்பிளி ஆச்சு, for example day after, I don't want to say that, but ஒரு பர்சனோட பெரிய மாநாடு நடந்துச்சு ஆக்சுவலா மதுரையில். ஸோ நிறைய so in the மாதிரி பெரிய huge gathering இருக்கும்போது obviously any medical emergency is very very mandatory, yes or no? Even recently in Andhra Pradesh, Telugu states also, one hero or a movie போகும்போது they are rush up and one person is dead because of it. All the time we need a medical emergency. Likewise, they are very precaution in Dubai and all those other countries. They are having the teams over there. Okay, yeah. They have to simply say, my friend, I'm just a little jealous about her. Simply she's taking photos with Virat Kohli and all those super awesome peoples, clicking it, they're posting in her Instagram. So that's her work. I mean, for example, she had to monitor if any emergency case happens, on the time she had to go, she had to leave, she had to get back to her place. That's her work actually. And சொல்றதுக்கு ஈஸியாக இருக்கும், 1.85 salary, easily they can able to pursue, they can able to buy a bungalow and all those stuff and all, but they have to work hard. That is also a main thing. And this is for example trending la போகும்னு சொல்லுவாங்க இல்லையா, some recent trending in actually Nagarjuna, Simon, it's very trending nowadays, right? Likewise இப்போ allied profession la so big highly demanded course னு சொன்னா it's trauma care management, paramedics and advanced paramedics. Critical care technology படிச்சவங்க, emergency service, trauma care management படிச்சவங்க, they can able to pursue 2 years of experience, DCAS examination. Talking about they are having on internet, important point outs as well. In India, they have to get 2 years of experience. They have to work under some hospital. They have to get 2 years of continuous experience. Another எல்லாருக்குமே இது காமன். பிரேக் எடுக்கக்கூடாது. ஃபார் எக்ஸாம்பிள் I just want to work for 6 months, after 3 month break, after 1 year, after 4 month break. No, continuously you should have 2 years of experience. 1 month to 2 month break is not at all a problem, but it should be in a controlling line manner. Experience certificate, very, very, very important one. And second thing is talking about their traumatic management's criteria. They have to crack exams here, which is BCAS. Second thing is they have to crack exam in Dubai also as well. They have to go there and visiting visa. They have to attend some ACLS, BLS, and they having live cases. In that also they have to crack their examination. Once they are practically passed and fit, they are elected, they are recruited under DCAS, then as soon as salary எல்லாமே கிடைக்கும். Okay, clear. Talking about another also equal demanding course in abroad countries is nursing. Nursing or demand worldwide is very, 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 very high. India is the largest supplier of healthcare professionals. India is the highest. For example, I was working in America. Most of the medical field people are from India, North India, South India. It's not like India. Commonly they are having recruiting every people from India. Okay, other number one, Kerala. Which state? Kerala. Malayalis. Other which district? Kottayam. So their nursing demand is very, very, very high globally. Okay, so directly they can able to go to Ireland, New Zealand. I mean, directly going is very, very little tough, but still you can able to go after your preliminary experience in Western countries as well. Okay, this is how it is. Nursing also, BSc, after registration as a registered nurse, 2 years of experience in India. Some countries are recruiting with 1 year also as well, but I won't prefer that. Go with the 2 years of experience. They will get, you will get a good pay. Nalla pay kadaikum. 2 years after, you can able to proceed for. Okay, la. And in India, you have to work. Whatever the hospitals are, NABH, non-NABH, hospital should be true, and you have to work. After that, you can able to post it there. And second thing is, many nurses students will ask that, sir, na dialysis nurse, dialysis na OT, scrub nurse na veno. Why Raja? So there is not a particular streams is not there. Everyone common under nursings, they can able to work under any of the department what they are preferring. Anga pona to the kapama, you can able to change your respective departments. Okay, there are a few categories what I want to share with you, and like commonly many people are doing. Like personally, I am from dialysis department actually. I was being in the field for past 6 years, and last 3 years of giving promoted coachings, and all since 2022 I started actually. So apart from my side, I now mattum coaching கொடுத்துட்டு கிட்டத்தட்ட 43 peoples we are given coaching, and 43 peoples we are placed in all the Gulf countries. நீங்க சொல்ற எல்லா Gulf countries-லயும் we placed our students there. That's what we are doing. And our team is also working with us, like NSS crew actually. We are having board members from different hospitals. They are working. They are professors, head of the departments, assistant professors from Reshma ma'am, Sneha ma'am. Many people are there. Pawan, Monica. Many people supporting bones are there actually. Many Ashwin's, many industrial famous people, head of the departments, PhD holders. Everyone are being in that team. That's what we are doing it up. And second thing is, talking about the examinations and romantic tests, we are going to be filtered up, and we can able to proceed to the next steps. And yeah. So we are having some talking about the Gulf countries. I make it as sweet and simple. Saudi, we have to go for Saudi Commission examinations. Again, as on the same formula now. 2 years of experience, registration after registration. Okay. And UAE, our countries like Dubai, I mean, under pre-registered it will be there. DHA, HAR, MOH and all. For all those stuffs also, same criteria will be applied up. Qatar, Oman, Kuwait and Bahrain, all those stuffs comes under the same registration and patterns. So move on to the next slide. Eligibility criteria. As I told you earlier, first, healthcare, degree or diploma. Okay. Minimum 2 years of experience in where? India. Very good. Then, prometry, exams, everything, license. Okay. And data flow. Do you know about data flow? Like data flow, data flow verification and all. Simple and so. For example, in a passport apply there will be a police verification will be there. Yes or no? Whether it is genuine or not, like this. This is also an agency concerned and works under Indian government and embassies. Okay. What they will do in the sense, they will cross-check all your attestations and all your original certifications. For example, your degree, your masters, your working experience, and all those stuffs what you submitted. For example, I need some few requirements. I mean, documents and the documents I will go and submit that. They will shortlist and they will check where you are your work, where you pursue, where you are start up your career. Like they'll ask question. For example, if you're placed in Sri Venkateshwara Hospital as an OT technologist, okay, 2 years you work pondering. After you will given experience letter. Yes or no? You will get an experience letter. In that experience letter, you will scan, you will send it to a documentation. Those preliminary work actually that we will do for you. Okay, our team will work for you. So you will be in a PDF manner. We will upload to the government. In that, what they will do, they will mail to all the universities. By, for example, if you study in Venkateshwara University, they will go. If you worked in Venkateshwara Hospital, they will have a mail. Mail call direct. We send a mail from data flow. Please, verify it like this. Once the professor, owner, or any healthcare professionals like registrars, they have to cross verify it. They have to see it's genuine. For example, fill the form. They will enter your joining date, your ending date, when you are going to complete, where you are going. When did you start it? When did you end it? What about your contact character? How is your performance on that? They have to good update go to sign go to Amjaro scan money. Sign seal, hospital seal, they will verify it. It takes 1 month of time, 25 working days, 25 to 45 working days it will take around say. In that, your verification will be done. So this process is called data flow verification. Okay, well. Some countries, for example, some countries, only one country, Dubai country. If you want to go to Dubai, this is data flow right now. Data flow is not mandatory. Once you pass your DH exams, you can able to proceed for data flow process. Okay, ma'am. But all the other countries like Saudi, Oman, Qatar, Kuwait, you have to start the data flow. After that only you have to appear for the examinations. Clear? Designed out, but it's little bit costly. Paisa good actually. It takes nearly 30,000 rupees maximum. So does the Max Pro. Okay, after a long time, Akash told that only this money paisa is asking extra, we shouldn't blame me, right? That's what I'm telling you. So it takes nearly maximum 30,000 rupees for only the verification purpose. Okay, and your examination fee comes under 18,000 rupees to 24,000 rupees for all the exam category peoples. It will be very from department and times, but still all across. Okay, and this is a last point I just want to tell people. Documentation need for data flow. Documentation what is that? All educational certificates actually. My candidates who came for our institution, they will ask that I know what is that? And the college migration, transcript, they didn't collect anything from it, but directly they will come for data flow. So don't do the mistakes and all. First thing you need all the educational certificates from your hand. And second, council registration. For example, so table about membership about OT also as well. They have to register in that. After registration, 2 years of time, you can able to fly to abroad and whatever country you want. Okay. So council registration is very, very mandatory. People will come to us, come to our hand, so in the 2 years, I wish to work in abroad, but I don't have enough super perfect. Where is the council registration? What is this, sir? I think Pocha, 2 years, okay. Second, again, after registration, 2 years, I mean, work, which means 4 years, you can able to see abroad. That much situation will be there. So don't suffer like this. Once, if you crack your BSc, apply for paramedical council, like AHP is in Kerala, they are affiliated, and for radiology, ISRT actually, physician assistant, IAPA. IAPA is the standardized one. Okay, you are doing IAPA for radiology, ISRT, for dialysis, IADD. So many different councils is there actually, so they have to push on her. Okay, and experience letter. Never ever lose your experience. 1 year work for another, 1 year work for another. For example, challenging will be there everywhere. Every place is not a comfort zone. We have to work out from a comfort zone, right? So everywhere we're having challenges. Wherever you are, you have to work 2 years for sure. Whether you want to break that in a sense, immediately you can able to join in another hospital. That will be a better idea for that. Okay, make sure you work on experience certificate. Collect from past work on a place, you have to collect experience certificate, which means that for example, if you're coming to me in a sense, I need your 2 years of working experience by the date. 1 month gap is not at all issue, but I need continuous of 2 years of experience. Okay, clear? Passport, passport if you have passport are very, very important. Passport is going to be a gate pass for your examinations. Okay, you have to take a data flow form and you have to take a passport to get into the examination center, right? And good standing certificate. Some countries need it, some countries don't need it. Good standing certificate. Now your membership council, like your IADD or SRTC, if you are being as membership in a sense, they will encrypt a certification of good standing for you. They will mail you off. That's more than enough for you people to work on it for data flow process. Okay. As I told you earlier, it takes 45 working days for sure. Yeah, whatever I said now, more that photos are. So I added that actually. So preparations and processing. Ella a question is now. The Muslim will discuss okay, ma'am. Duration of courses. For example, in Prometric, in our Gen Academy, what I am doing, what we are doing, in a sense, we are giving a pitch. I mean, we are training the people. For example, in India, follow protocols, abroad, there is some small changes will be there. They will check your clinical and as well as your theoretical knowledge also as well. Right? So, what we are going to do in a sense, we are going to brush up what we are giving in Gen Academy. It's actually a simple thing. You are having only 3 attempts in your entire lifetime. Yes or no? Yes or no? You are having only 3. No, yes, no. You are having only 3 attempts in your lifetime actually. What we are doing in a sense, for example, if one person is coming, example, Vetri, after completing his internship, after completing his 2 years of experience, Vetri is getting back to us. Akaza, hi, hope you're doing good. Like, and on the abroad, I want to go to abroad. What I have to do? First, to make sure which country you want to go. That's the country the first number analyze by do. And the country kind of exams. We are start giving coaching for them. We will give a coaching for them. Train for the PhD holders. People who are doing PhD, people who have completed doctorates, going to be your trainers and tasks. All those stuff they are going to take care of people in an entire training purpose. It's going to be a live discussion class. Live discuss on the topic. For example, like many people having worried about your skill stuff. So I don't have a proper vocabularies. I'm having some language issues. Like many people are having. Feel English confident feel now tip actually. Now feel once upon a time. Anyone felt about it? Very weak. Stage based or famous person in a base of English base of worry proper delivery feel I'll give it. So actually, now once upon a time, I am also not from California, Florida, I'm Gucci, actually. I'm both Chennai, Ananagar. Okay, yeah. So I also tried, like, they have to, a small, drops of water makes the ocean one day, right? We have to do a proper one by one step. You are being in a first year, second year, third year, as soft people, this is a correct time to awake. First year, no problem, you sleep for some while also. Third year, internship, very important time for you people. This is a very pretty and precious time for you people get to awake. Okay, yeah. Competition it's very heavy outside. Very heavy outside. Okay, so we have to be aware about what you're going to do in your next step and also. Even I am also a small kutti small story actually. When I was in college time, in the first year, physiology classes, I got a presentation in front of 163 people actually. என்னோட பார்ட்னர் நானும் என்னோட ஃப்ரெண்ட் co-person ரெண்டு பேர் தான் வந்து சொன்னாங்க. அந்த குளோபுலர் பேஸ்மெண்ட் மெம்பரேன் டாபிக் நெஃப்ராலஜியில் குளோபுலர் பேஸ்மெண்ட் மெம்பரேன் தான் டாபிக் ஆக்சுவலாக நெஃப்ரானில் ப்ரெசென்ட் பண்ண சொன்னாங்க. யூ கான்ட் பிலீவ் ஐ ஆம் த ஃபர்ஸ்ட் மார்க். ஐ எக்ஸ்பெக்டட் பட் அங்கே தான் ட்விஸ்ட்டு. அசெண்டிங் ஆர்டர் இல்லை, டிசெண்டிங் ஆர்டர். நீங்கள் அதுக்கப்புறம் கேட்கலாம் பண்ணீங்க. Thank you. Anyways, thank you. ஏன்னா நான் தமிழ்ல பேசணும்னு சொல்லிட்டு sir told me don't use any local languages while you are giving presentation சொல்லிட்டு presentation ஒன்றும் பண்ணல actually. I got 7 out of 25 I guess 25 15 something down figure. On the day I was felt little normal last month actually. No one is this 7. I got some courage. பயம் ஆயிடுச்சு actually. இத்தனை 150 people பார்த்த உடனே hands, legs on the vibration mode of which voice or something elaborate. So on that day I was fixed. I just want to improve my skills and stuff and all actually. Number friends get English பேசினா என்ன சொல்லுவாங்க? பீட்டர் பாகன்வாங்க, பீட்டரே actually. பண்டாடா பீட்டர் அப்படின்வாங்க. Obviously அந்த ஜெனரேஷன் தொட்டு அந்த காலம் வசந்தன் தோல் வர மாதிரி அந்த காலம் தொட்டு இந்த காலம் வரை பீட்டர்ன்றது மாறவே மாறாது actually. If you talking with your friends, yes or no? கலாய்ப்பாங்க, பயங்கரமா கலாய்ப்பாங்க. பேசும்போது அம்மா கிட்ட போயிட்டு அம்மா வாட்ஸ் டின்னர் அப்படின்னு கேட்டா ஹே பாப்ஸ் வாட் ஆர் யூ டூயிங் நவ கலி சமுட்றோம். சோ how you can for example நீ பேசும்போது ஃப்ரெண்ட் தான் பாய் அது உங்க இஷ்டம் பாய் ஃப்ரெண்ட் கேர்ள் ஃப்ரெண்ட் that's yours. So whatever it is, if you're talking with a person, they have to encourage to talk in English or in your language which you want to talk with them. Okay? Number friends, தெரியும் கலாச்சே கொண்டுருவாங்க அல்ல. You know how I train? You know how I get trained? Speaking தனியா பேசுறதா மென்டலா தனியா பேசுறது. How? எனக்கு என்னப்பா கேட்ராமாவா? அப்பெல்லாம் அது கிடையாது. கொரியன் டிராமாஸ் பார்ப்பாங்க, சைனீஸ் டிராமாஸ் அதுவும் இல்லை. I am fan of TF5 Telugu film industry, not others. Okay, talking drama. Hey, talking drama, he can't able to ask you questions, right? நீ பேசணும்னு பேச talking drama இல்லையா? How? அதெல்லாம் அப்ப இல்லடா. Say now also we have Indian government, we are using that. No, who is using that actually? 1 or 2 something. Newspapers. நான் படிக்கவே மாட்டேன். சேனல் வச்சாலும் மாற்றி விட்டுருவேன். அது வந்தாலும் நம்ம கேள்வி அப்படின்றாங்க. வேண்டாம் இல்லை இங்கிலீஷ் மூவி பார்க்கணுமா? நோ. See, நீ பார்க்கறதுனாலும் கேட்கறதுனாலும் இங்கிலீஷ் டெவலப் ஆகாது. While talking to someone else, it's going to be automatic in a peak. Okay, va? பேசுறதுக்கு டைமும் கிடைக்காது, பேசுறதுக்கு ஆளும் கிடைக்காது. You know what I did? அப்போ Airtel இருந்தா Jio வரல actually. I will call the customer care executive. தமிழுக்கு 1 என்ற எழுத்து அப்படிமா? No. Press 2 for English மா? Yes ன்னு press பண்ணேன் because இஸ் அ கஸ்டமர் கேர் சர்வீஸ். நீ என்ன தப்பா பேசினாலுமே உனக்கு திட்ட மாட்டான், உன்னை கலாய்க்க மாட்டான். நீ எங்கேருந்து பேசுற, யார்கிட்ட பேசுற, நோ ஒன் நோஸ் அபவுட் யூ, ரைட்? தெரியுமா? ட்ராக் பண்ணுவாங்களா? வீட்டுக்கு வந்து கேவலமா இங்கிலீஷ் பேச சொல்லுவாங்களா? சான்ஸ்லெஸ், ரைட்? I'll dial 191. Wait for the person. தமிழுக்கு என் மன்ற எழுத்தவும். No. For English press 2. Yes, I press it out. Press 9 to connect with the customer executive. பேசுற இங்கிலீஷ். Sir, I have a plan. I started with this, that ன்னு சொல்லிட்டு ரொம்ப ஓட்ட இங்கிலீஷ்ல பேச ஆரம்பிச்சதுனால தான் லிட்டில் பிட் ஆஸ் கொஞ்சம் கான்ஃபிடன்ட். நீங்கள் கொஞ்சம் நல்லா பேசிட்டு இருக்காங்க முன்னாடி. ஸோ இது நீங்கள் டிப்ஸாகவும் எடுத்துக்கலாம், ஒரு என்கரேஜ்மெண்ட்டாகவும் எடுத்துக்கலாம். ஸோ what I'm telling you, what I'm coming to tell you from this instance, whatever the worst situation, try to dive in that. Whatever the worst, whatever the hard situation, try to dive in that. That's what I want to say in that actually. So people's, please, crave your, skills, uplift your skills, soft skills, do some basic activities and get enrolled and engaged. You are not getting an opportunity to talk with your people's friends and all. But interview abroad interview போகும்போது நீ தமிழ்ல பேசினா அக்செப்ட் பண்ணுவாங்களா? Yes or no? Obviously no. But here we are giving a space to talk to someone else. For example, online classes இருக்கும், live discussion classes இருக்கும். We are going to recruit only 5 people in a batch because online classes பத்தி எல்லாருக்கும் தெரிஞ்சது இல்லையா? It will be an little bit கொஞ்சம் டஃப்பான ஒரு situation தான். In that we are going to discuss with some other peoples. They will be interact with us. Yes or no? So in this we are going to give a live discussion classes, weekly sessions, mock test, and after, for example, 3 months of duration end of 3rd month or starting of 4th month, we are going to conduct a demo interview. Abroad எப்படி உங்களுக்கு இன்டர்வியூ கண்டக்ட் பண்ணுவாங்களோ அதே மாதிரி ஒரு என்விரான்மென்ட் கிரியேட் பண்ணி we will conduct a demo interview for your peoples. Once the demo interview said that you are qualified in a sense, easily we will let you to do the examinations because we having a policy that இப்போ வரைக்கும் ஜென் அகாடமில இருந்து பாஸ் ஆன பீப்புள்ஸ் எல்லாமே ஃபர்ஸ்ட் அட்டெம்ப்ட்ல பாஸ் பண்ண மாட்டாங்க. கிட்டத்தட்ட 70 இந்த பேட்ச்ல மட்டுமே 78 பீப்புள்ஸ் இருக்காங்க. என்டையர் டயாலிசிஸ், ரேடியாலஜி எல்லாம் சேர்த்துட்டு. ஓகே, this is what our philosophy, what you are following in our life. First attempt, first win, first dose. So we are not like slow and steady wins சொல்லுவாங்கல, அந்த பாலிசி ஃபாலோ பண்றோம். Slow, steady, you will make you update your skills, soft skills or interview cracking skills எல்லாம் செய்துட்டு for demo interview. After you are well fit enough to appear the examinations, we will let you to move the main examination because ஒரு எக்ஸாம் ஓட ஃபீஸ் எவ்வளோ? உங்களோட மாச சம்பளம். மேபி பேசிக்காக ஒரு பர்சனோட மாச சம்பளம் என்ன? ஆஃப்டர் யுவர் அலைட் கோர்ஸ் 15 to maximum 25. Yes or no? Yes. That amount you're going to pay for your exam fee. ஒரு மாசம் salary போச்சுன்னா எப்படி வரி, ரைட்? அந்த கஷ்டம் வேண்டாம்னு சொல்லிட்டு தான் we are doing it in the manner. Right? This is the concept all about it. And எவ்வளோ ஸ்பெண்ட் ஆகும்? ஃபார் எக்ஸாம்பிள் how much will cost for people அப்படின்னு கேட்டால் ஓவரால் காஸ்ட் துபாய் போகணும். ஃபார் எக்ஸாம்பிள் if you want to go to any GCC countries, சிம்பிளாக முடிக்கலாம். If you want to go any GCC countries, 50,000 rupees to 70,000 rupees. 50,000 rupees for Dubai. அதாவது coaching, data flow, your examination, all those stuff எல்லாம் ஃபில்டர் பண்ணிட்டு you gonna pay up 7,000 rupees. Entire process முடியாது. It will take nearly 6 months of time. கொஞ்சம் எக்ஸ்பென்சிவ் தான், கொஞ்சம் காஸ்ட்லி தான், but we have to, this is a basic foundation. Without the papers you can't able to get job. For example, many people text me in WhatsApp, Akash, can I able to be part of Gulf countries? Yes sir, sure, why not? I am fresher basically. So he's a fresher, like we haven't trained them up. அதனால இப்போ நான் உங்களை வந்து ட்ரைன் பண்றேன் actually. Okay, without 2 years of experience, don't proceed anything. Without having all those stuffs, don't proceed anywhere. This all are very, very, very mandatory. Okay, clear? Tips for preparing. Yeah, we having an MCQs type discussion and prompt questions. We having our own website. You can able to check it out. Own website, LinkedIn profiles, and your LMS system, learning management system, will be available in Apple and iOS and Android also as well. You can able to download from Play Store also as well. So these are the gen applications. In that you can able to do all those stuff and more. And timely mock examination points up. Here you can able to study online as well as offering. For example, I am talking with the people, my network, my team, my strength, my directors, those directors working behind me. When I was talking to people, someone is taking some classes for EEG technician students. We're having on Ms. Neha is there. She is in course director of neurology department. She's taking classes for neuro students now. Neuro director of physiology people. And Hema ma'am is there. She is in dialysis people who is taking care of dialysis. She is studying there. And talking to OT80, we have Reshma ma'am. She is taking care of all those OT80 students as well. Trauma care, we are having Dr. Anviksha from Meghalaya. She is taking classes for you peoples. She is working in Apollo as an head of the department and professor, so assistant professor something. So likewise, we are having all the graduates, highly trained, highly knowledge, highly expertise in the field of AHS. They are going to train you peoples. And we are having a language component also. Right? We will train you for the language purpose also as well. This is what we are doing for past this many years, and we're going to step into this first year. We're having two brands, one is in Kerala, another one is in my own brand, is like Gen Academy. We're going to step September 13, 14, 15 in the days to come. We're going to get into 1 year of our victory. You can't believe that, even I can't able to believe, in the past 1 year we trained nearly 80 plus people. It's not a small number for me. I was started this academy in 2022. 2022 start பண்ண என்னோட earning savings எல்லாத்தையும் போட்டுட்டு start பண்ணி loss. People's who are in website developers, all those people cheated, full crash. Life let me crash வரும். அப்பதான் நம்ம again Phoenix மாதிரி reborn பண்ண முடியும். Then I started in 2024. 2024 can come back. Yeah, thank you for the word. Come back. September, within 1 year of time, I am praying to God to complete 100 people before this September is. We will pray for that also as well. So, not about the prayer for getting numbers. Numbers I don't need money. I need the name and fame that, sir, once upon a time, if I'm going for any other countries, I have to see my students who are passed from Gen Academy. So, because of you, I was being there, sir. Thank you. Like, I'll get some messages from our past students actually. Like one of my first student from Trauma Care, Lokesh. He is in Dubai, he is getting 1,85,000 rupees salary. We trained him, we placed him in that country. He touched me. So, thank you so much. Vaipa. Without you, I can't able to be there. Third word gives me a boost to all these complex. He's telling that, sir, I am from a normal middle class family background. I am earning 1.85 lakh salary because of you. And he is training my students. Next week on the flight actually. Okay. Next week he is placing 2 people. We are not charging. I mean, I want to clear the word. I am not a consultancy agency. Like our consultants and 5 lakhs give me 5 lakhs, I will place in this country, that country. No. We are giving all the placements for free of cost. We are not charging any amount. We are charging money for the training, coachings, and all those paperwork from our side. Students who are working because of us in different countries, still now we are having a proper rapport with it. Like look at all the 5 lakhs now 1 meter. Now come the country, I will place you there. I will go. I'm not worrying about the money. My students have to place in some different countries. That's what I want at the end of the day. Satisfaction. Thank you, sir. The word thank you means a lot for me. You have to tell me, hey, go to Gen Academy, go to Akash, he will take care of it. Their team will take care of us. They will guide in a proper manner. That's more than enough for me in this hour. That's what my dream and my vision also as well, right? And finally, yeah, we are what service we are giving in a sense, we are giving an online coaching and placement assistant. I'm not ensuring that I will place everyone. Trauma care, I'll give placements. Nursing, 100% I'll give placements, right? And all the other category also, technologists, cath lab, cardio, we are placing up. These are giving placements completely from Trishul. Chalapudi, and one person, Lalit is still on process actually. Likewise, we are in Anjana Paulson, she is from Kerala, Ernakulam, Kochi. She's passed her eco-technologist course in Dubai. She's going to move as soon as possible. So, likewise, we are doing in different countries with different peoples, different state of peoples, we are working it out. And eligible criteria works, council registrations, exam and general booking, and BSS training, what not, everything we are doing here. for that. And this is a salary package for starting beginners actually. Just have a look on it. Starting 80,000 rupees to 1.5 lakhs for sure, then you can able to get it up. This is a preliminary package. It is a preliminary package and depends on a company to company, hospital to hospital, it will change it up. Right? This is the qualifications. For example, which are the countries, how many students we placed, packages, what they're getting, exams, what they have to do. That's what we have, showing here. So, altogether, if you want to connect with us actually, if you're having some kind of a problem, if you want to see all the proofs, all the students in the sense, you can able to open your thing, you can able to share the slides. You can able to scan this out. If you scan this, it will be there in our profile. Everything you can able to see in our profile. You can able to contact anytime for free career guidance and all those stuffs. This is what I just want to talk to you people. Now I just want to discuss with from your hands. Yeah, you can able to raise your questions now. Different departments, nursing is there, cardiovascular technology is there, and physician assistant. Any questions? Got any questions really? I need some.
Nere questions are we have a lot of questions, but for the want of time, I'll post this number in the in-charge group. Okay, your in-charges will pass on this number to you. There's having a huge WhatsApp group. You can join with them. Every day he posts some 3 or 4 opportunities, advertisement. You can have contact with him. Okay.
Yeah,
so
sure.
Excuse me, sir, for the
no issues.
time.
No issues.
Yes or no? See, if you want to succeed, you have to do something. Okay. There is a saying in Tamil: "Karanangal solvavargal, காரியங்கள் செய்வதில்லை, காரியங்கள் செய்பவர்கள் காரணங்கள் சொல்வதில்லை." To make it short for the people who come from northeast, you can only do 2 things in life. Either you can make it, that is, you can make money, or you can give excuse. What are you going to do? Are you going to give excuse or are you going to make money? If you want to make money, there is a pathway for it. Follow it. First, start to speak in English. First thing, எல்லாமே technical நல்லா வளர்ந்துருவீங்க, but it becomes spoken words. You are struggling like anything. You get 10,000 na 10 மடங்கு ஜாஸ்தி ஃபாரின்ல. 1 lakh salary. What do you want? You decide. Okay. So without wasting much of time, let us honor the speaker from Bangalore with a big hand.
Thank you, sir, for such an insightful session.
Okay, before lunch, 1 o'clock ஆயிடுச்சா? Okay. மணக்குள்ள பஸ் போயிடுச்சா? யூனிவர்சிட்டி எக்ஸாம் முடிஞ்சிருச்சு. இனிமேல் நம்ம ஸ்டேஜ் நம்ம கையில் தான். ஆட்டம் பாட்டம் கொண்டாட்டம். மினிமலா ஃபர்ஸ்ட் ஆரம்பிச்சோம் லஞ்சுக்கு முன்னால ஷார்ட் ஃபில்ம். Only 3 short films are there. I think hardly 5 minutes each. After that we'll go for lunch. Okay? Enjoy. Judge, okay, Professor of Community Medicine, Dr. Surendra, will be judging the session and announcing the result. Thank you. Okay, not everybody, they are not going for lunch, they are going for lab visit. Students from Assam, they requested us to see our lab. So they are going for lab visit. Even at lunchtime, they want to learn something. They are not going for lunch. Still, if you want to go and wait. Lunch has not come. Let us enjoy a short film. நமக்கு சோறு தான் முக்கியம், ரொம்ப போய் நின்று முக்கியம். We'll give a separate queue for these people. but related to legal professionals. Please maintain silence.
ரிப்போர்ட் படிச்சு பார்த்தேன் பிசிஓஎஸ் கன்ஃபார்ம் ஆயிடுச்சு. பிசிஓஎஸ்ங்கிறது அவ்வளோ பெரிய நோயா டாக்டர்? இல்லை இல்லை, கவலைப்படாத, மெடிசனே சரி பண்ணிடலாம். ஆனால் ஃப்ரூட்ஸ் வெஜிடபிள்ஸ்லாம் சாப்பிட சரி பண்ணிடலாம். டைம் எடுத்து சொல்லுங்கள். மெடிசன்லாம் கண்டிப்பாக ஃபாலோ பண்ண சொல்லுங்கள். அப்போ சீக்கிரம் கிளியர் ஆகிடும். இவ்வளோ பெரிய பிரச்சனை இருக்கு, இதை பார்க்காம வீட்டில் என்ன பண்ணிட்டு இருக்கீங்க?
எனக்கு என்னன்னு தெரியுது இவ்வளவு பெரிய பிரச்சனை ஆகும்ட்டு.
சரி, இப்போ என்ன பண்ண போறோம்? இந்த நோய் இருந்தா யார் அவளை கல்யாணம் பண்ணிப்பா? லைஃப் போச்சு.
நான் எவ்வளவோ சொன்னேன் அவளை உடம்ப பார்த்துக்கோன்னு சொல்லி, ஆனா அவள் என் பேச்சை கேட்டாதானே. இப்ப எங்க கொண்டு வந்து நிறுத்திங்க பாத்தியா?
அதனால என் உயிர் வந்து கொஞ்சம் கொஞ்சமா போயிட்டு இருக்கு இப்பவே.
எனக்கு பேச எனக்கு அதுதான் டெய்லி ரொம்ப என்ன நடக்குதுன்னு நான் மறந்துடுவேன். எங்க அம்மா பேர் கூட நான் மறந்துடுவேன்.
ஓ, அது ரொம்ப கஷ்டமானது.
ஆமா, ஆனா நான் இன்னும் உயிரோட இருக்கேன். என்னோட டெய்லி லைஃப் புதுசு புதுசா இருக்கு எனக்கு ஒவ்வொரு நாளும். அதை நினைச்சு சந்தோஷமா வாழ்ந்துட்டு.
ஆனா எனக்கு வாழவே பிடிக்கல, நான் சாப்பிடறதுதான் மேல்.
நீங்க எனக்கு வேண்டியவங்க. நான் இப்ப உங்களை காப்பாத்திருக்கேன். அது மாதிரி நாளைக்கு நீங்களே என்னை காப்பாத்தலாம். உங்க பேர் எனக்கு வேணாம். ஏன்னா என்னால உங்க பேர் கூட நான் வச்சுக்க முடியாது.
உங்களை பாக்குறப்பதான் எனக்கு வாழ்க்கையோட அர்த்தமே என்னன்னு புரியுது. நான் இனிமே இந்த தப்பை செய்ய மாட்டேன்.
இந்த வாட்சை வச்சுக்கோங்க. என்னைக்காச்சும் ஒரு நாள் எங்க ஞாபகப்படுத்துற ப்ரூவ் பண்ணிட்டு கிஃப்டா இருந்து போட்டோம்.
என்னங்க உங்களுக்கு கொஞ்சம் கிளாரிட்டி இருக்கு, உங்க பேசுற பயமே தெரியல, இவ்வளவு கான்ஃபிடண்டா இருக்கு. ஆமா டாக்டர், நான் இனிமே எதுக்கும் பயப்பட போறதில்லை. ஏன்னா வந்து என் லைஃப்ல வந்து எவ்வளவு பிரச்சனை வந்திருக்கு, அதெல்லாம் நான் வந்து ஃபேஸ் பண்ண கத்துக்கிட்டேன், ஸ்ட்ராங்கா ஃபேஸ் பண்ண கத்துக்கிட்டேன். நீங்க எனக்கு ட்ரீட்மெண்ட் ஸ்டார்ட் பண்ணுங்க டாக்டர். எனக்கு இருக்கிறது ஒன்றும் பெரிய பிரச்சனை எல்லாம் கிடையாதுமா. டாக்டர் சொன்ன மாதிரி ட்ரீட்மெண்ட் எடுத்தா நம்ம சரி பண்ணிடலாம். நீ எதுக்கும் நீ கவலைப்பட்டுக்காதம்மா.
நான் கோவப்படுறது உங்க மேல இல்லைன்னா எனக்கு வந்து அவளை பத்தி புரியும். நான் எதனால கோவப்படுறேன், என்னால இதை புரிஞ்சுக்க முடியலன்னா நான் கோவப்படுறதை தவிர உன் மேல எனக்கு கோவம்லாம் கிடையாது. மத்தவங்க சொல்றதை பத்தி நான் கேட்டுக்க மாட்டேன். ஏன்னா எனக்கு நீதான் ரொம்ப முக்கியம். எதுனா இருந்தாலும் நம்ம ஒன்னா சேர்ந்து பார்த்துக்கலாம்.
உங்களுக்கு என்ன தெரியுமா? உங்களுக்கு என்ன தெரியாது, ஆனா எனக்கு வந்து உங்களை நல்லாவே தெரியும். என் லைஃப்ல வந்து ஒரு முக்கியமான பர்சனே நீங்க தான். தேங்க்யூ ஃபார் கமிங் இன்டு மை லைஃப்.
It was nice and small movie. Movie எதாவது பேர் வச்சிருக்கீங்களா?
Synapse, actually.
Spelling?
SY
Spelling?
NA
NA
SP. Synapse.
Yes. It's a word PCOS being diagnosed. அவங்கள சூசைட் அட்டன் பண்ண போறாங்க, ஒருத்தவங்க காப்பாற்றுறவங்க ஹேவிங் அல்சைமர்ஸ் டிசீஸ் and they meet after 5 years period. இன்னும் அதை வாட்ச் இருக்கு.
It will be like she will get this ray of hope from that Alzheimer girl. Like நம்மளோட இங்க நிறைய பேர் வந்து வேற நிறைய டிசீஸோட இருக்காங்க. நம்ம கம்பேர் பண்ணுறப்ப அந்த மாதிரி நம்ம ஒரு சின்ன டிசீஸ் அப்படின்னு சொல்லிட்டு ஒரு ஹோப் கிடைச்சிருக்கு. அதுல
something is better than nothing. அது ஆட் பண்ணீங்கன்னா இன்னொரு மார்க் எக்ஸ்ட்ரா கிடைக்கும். ஃபைன், தேங்க் யூ. நைஸ் அட்டெண்ட்.
Next team, அதே மாதிரி உங்க முடிவு சமைச்சா come to the stage. Okay, time இல்ல, lunch time ஆயிடுச்சு. Come.
Syringe. Syringe.
Syringe from which college?
Joy University. Okay. One liner about the movie.
A tribute video for all OT technicians, maybe.
Maybe, okay, fine. Thank you.
Thank you, sir.
Next team, you can come to the front row to save time. Next one, please.
Good morning, students. Sit down. Answer the attendance. Sri Devi, Sneha, Shivatali, Kishore. Katie. Yeah, Nathan.
Let us, ma'am.
Good afternoon, all. Sit down. தம்பி ஒரு ஃபேக்கல்டி வந்திருக்காங்க, போன வருஷம் நீ பார்க்க வந்திருக்க, ஒரு ரெஸ்பெக்ட் இல்லை, ஒரு மரியாதை இல்லை, என்னதான் ஸ்கூலில் சொல்லி கொடுத்துருக்காங்க, அப்படியே ஒரு ரெஸ்பெக்ட் இல்லாமல் உட்காந்து இருக்கிறது. நன்றி நன்றி. கெட்டப் வந்துருக்க கெட்டப் என்ன கிளாஸ் பக்கமே வந்துடக்கூடாது, சரியா?
May I come in, ma'am?
Good evening, sir. What is your name?
Sanjay.
Listen, students, he is your new friend. Sanjay, please sit down.
Hey, gimana? காலையிலே பகல் காணவா மேலே பார்த்துட்டு இருக்கிற? ஏய் சவுண்ட் பாக்ஸ் நீ வா.
எதுக்கு சவுண்ட் பாக்ஸ் கூப்பிடுற? எங்களுக்கு பேர் இல்லையா?
பேர் தான் சொல்லிருக்கா.
ஏய், என்னடா மெசேஜ் பண்ணி வச்சிருக்க?
எனக்கு ஒரு மாதிரியா தான் இருக்கு, வாடா வெளியே போலாம்.
சொல்லு மச்சான், அதை ஃபீல் பண்ணி
அதான்
சொல்லு.
சொன்னடா மச்சான், சரியா தப்புக்க மாட்டீங்கன்ட்டு.
அதெல்லாம் பிரச்சனையே இல்லைடா, எல்லாமே நார்மல் ஆகும்.
முடியல மச்சான், வீட்லேயும் சரி வெளியும் சரி வெறுக்க ஆரம்பிச்சிட்டாங்கடா ரொம்ப.
அப்படிலாம் ஒன்றும் இல்லைடா, நீ 2 பேரும் வந்தாலே எல்லாமே நார்மல் ஆகிடும், எல்லாம் சகஜமாக பேச ஆரம்பிச்சுப்பாங்க.
நானும் மாறணும் நல்லா ட்ரை பண்ணுறேன், முடியலடா.
முடியும்டா, நீ மாறணும்னு நினச்சா முடியும், எல்லாமே மாறும், நார்மல் ஆகும், பார்த்துக்கலாம்.
ட்ரை பண்ணுறேன்டா. டேய், எப்படா இருக்க?
எங்கடா வாழ்க்கையே தொலைச்சுடா.
ஏன்டா என்ன ஆச்சு?
இந்த போதையால என் லைஃபே போச்சுடா.
இந்த கருப்புனால தான் அவன் வாழ்க்கையில் ஒரு விஷயத்தை தொலைச்சிட்டு நிற்கிறான். நீ பாரு வாழ்க்கையை தொலைச்சிட்டு நிற்கிற, நான் நீ காலேஜில் என் மானத்தை தொலைச்சிட்டு நின்னேன். இப்போ பாரு எனக்கும் ஒரு லைஃப் இருக்கு, நான் நினச்ச மாட்டேன், நீ என்னடா மாறலாம். சரி வரண்டா.
சரி மச்சான், நீ பாடுறா.
இவனை மாதிரி இந்த போதைக்கு நான் இன்னும் அடிமையாக இருந்தால் இந்த நல்ல நிலைமைக்கு வந்துட மாட்டேன். இது எனக்கு கிடைச்ச 2வது முயற்சி.
Okay, இதெல்லாம் வாலண்டியர்ஸாக இருக்காங்க. They are not in the stage. Okay, we'll meet up. Judges announcement will disperse for lunch. அதுக்கு முன்னால சில faculty they want to get the certificates. Okay. போகும்போது அவங்க வந்து certificates வாங்கிக்கலாம். Say institutes, they need the certificate from itself. Okay, we arrange the certificate, you can get it while going for lunch. Participation certificate. முடிஞ்ச அளவுக்கு by 3 or 4 o'clock நீங்கள் ரூமை கொஞ்சம் வெக்கேட் பண்ணிட்டீங்கன்னா அந்த பெட்ஷீட்ஸ்லாம் நாங்கள் ரெண்ட்டுக்கு எடுத்தோம். They will not charge for 1 more day. 5 o'clock we will return now. So try to cooperate. Okay. So far you have given a very good cooperation. We need to extend your cooperation. That's all. Some of the judges will have done also.
Good afternoon all. I have to select 2 prizes for the event. One is a runner-up and one is a winner. Runner-up is Joy University's short film. And winners are from SVC BMS. One is on concept, second is on cinematography, third is based on acting, fourth impact caused by the short film. I have given the scores to sir, and here pros and cons of each movie has been listed. You can contact sir for details. further doubts, you can come and contact.
I request Joy University to come and receive the trophy. Come.
సినిమాటోగ్రఫీ కావాలి ఫస్ట్ వేసి కూడా ఇది ఆడియో కదా ఉన్నాడా ఆడియో రకం
இதில் விளையாடுறது இல்லையா சத்தியமாக கடுப்பாயிடும். நான் வெளில வைக்க சாப்பிட்டு வந்து கூட காலேஜ் போயிட்டேன். இல்லை நீங்கள் சாப்பிட்றேன்
இப்போ ரெண்டு பக்கம் ஈக்குவலாக இருக்க பாருங்க. இந்த டென்ஸாக இருக்க இந்த தின்னா ஒருத்தர் இந்த பக்கம் பார்ப்பாங்க. நீ சொல்லணும். எடுத்துட்டியா?
ബെൽറ്റിട്ട് അഡ്ജസ്റ്റ് നോക്കി എനിക്ക് തന്നെ ലൂസാത്
നമ്മളിപ്പോൾ അവിടെ കാണുന്നുണ്ടാവും ഞങ്ങൾക്ക് അവിടെ കാണുന്നുണ്ടാവും
Okay, now leave now itself up to lunch. Come. Winner of the oral presentation, faculty. One more round of applause. Thank you, Neema.
நீங்க இப்படி நின்னுக்கோங்க மொபைல் மட்டும் வச்சுக்கோங்க
பையனா சரி 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 நீ பாரு இதோ இல்லை இல்லை இதோ வரேன்
participants. Anybody ready? First performance of Dr. Umar. Last of Kamila. Okay. Meanwhile, yesterday somebody wanted to sing. Are you here? Let's not waste our time. Anybody? After cutscene on the liquid, I want. When the opportunity is given, you have to grab it. Anybody wants to sing? With or without karaoke? Okay, time up.
If anyone from Chettinad Academy of Research and Education, Chennai is here, please come and collect your certificates. And along with them, Tribhuvan M College, Manipal University, Sri Ramachandra University, and PIMS College, Excel, Kamachi College, Medical College, please come forward and collect your certificates. Also Frontier College, Chennai.
நான் என்ன பேசுகிறேன், நீ இல்லாமல் பேசுகிறேன். சும்மா சும்மா. ஓகே, ஃபர்ஸ்ட் பார்ட்டிசிபென்ட் யாருன்னு சொல்லுங்க. அவங்க 2 minutes டைம் தரும். இல்லாட்டி அடுத்த பேஜ் போயிடும். Who is the first participant?
For group dancer?
Yeah. Group dancer.
First we are having solo dance competition, sir. And the first participant is N.R. Jayanishwari, Frontier Lifeline Hospital, Chennai.
59, 58, 57. 1 minute வரலனா next chance. அடுத்தது போயிடும். Frontier Medical College. சார் என்ன பண்ணுமா? Sorry, 2 o'clock. Now it's 2:27. So on the Frontier Lifeline, I think they lose the chance. Okay, now who is next? What's your name? What's your name? Where are you from? K-Square, coming from Kamachi. All the best.
பார்த்தேனா கண்ணாடி முன்னாடி சரியானேனா உன் கண்ணு நீ வைக்கும் மையானேனா கொஞ்சம் கொஞ்சம் கைகள் கோக்கலும் ஜோடி சேர்ந்து லோமசாக ஊர சுத்தனும் பேண்டு வாசிச்சு கிராண்டா மேரேஜ் குட்டி மேலும் எங்கும் கேட்கணும் குடிக்காம ஓட்டுநரிலே இனிமே நீயே ஆளு அடியாத்தி ஒன்னான நான் கையில குடிக்காம ஓட்டுநரிலே இனிமே நீயே
இல்லை ஒரு 2-3 லைன் கொஞ்சம் நேரமாக
Yeah. భువన పాలినివే
பத்தி அவனுக்கு என்ன தெரியும்?
என்ன தெரியுமா? టీచర్ అక్కడ நம்மள பத்தி தெரியல. अभी देखो చూపిస్తాను. நம்மளை பத்தி தெரியல. அது देखो చూపిస్తాను.
சத்து சத்து அடி போட்டு
சிரிச்சா ரொம்ப அழகா இருக்கு பாரு.
எங்களுக்கு ஆடலும் பாட்டு நிகழ்ச்சி போட்டே ஆகணும், போட்டே ஆகணும்.
என்ன சொல்லுவோம் ஞாபகத்தில் இருக்கல?
பார்த்தா இந்த பக்கம் பார்த்தா பார்த்தா
இது என்ன பிரமாதம்? இதோட ஸ்பெஷலே ஒண்ணு இருக்கு.
பார்த்தா இந்த பக்கம் பார்த்தா படிச்சுக்கொள்ளடியோ
ஜீவி சக்கரையே சிரிப்பு சிரிக்கிறீயே அசந்தா அசந்தா ஒரு போட்டிருக்குது படிச்சுக்கொள்ளுவியே
Change the song. You babar. Padika, 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 Padika,
இதென்ன பிரமாவா? இதோட பிரசனைக்கு உங்களுக்கு
இப்படித்தான் குத்தணும்.
Dramatic performance by the DCM
ஒரு 1000 மாணவில்ல ஓம் பூவி காட்டலடி அத சட்டுன்னு நீ மறைச்சா என்ன செய்ய கொள்ள
அங்கே சேஞ்ச் த சாங்
இப்ப பாரு
Okay, for entertainment of the course now we have people from DDC Academy Pondicherry, our head judge. So he is going to entertain through his students. With a big warm round of applause, DDC from Pondicherry and their proud judge. Three cheers for Mr. Rajendran and his team.
சாப்பிட்டு மிச்சத்தை பார்க்கலாம்.
இது முடிச்சுதான் மறுவேலை.
எல்லாம் கரெக்டு தானே, ஆனால் வைப்லே இல்லாமல் எப்படிண்ணா?
வைப் தானே
ரைட்டு.
Dime que
ஏய் என்னடா கண்ணு கலங்குது ஆனா வாய்ஸ் இருக்குது
லவ் ஃபெயிலியர் மச்சான் பைலா இப்போ நான் சோகம் பாடணும்
சோகம் உனக்கு மட்டும்தான் எங்களுக்கு இல்லை நீ நல்லா வைபா படி
ஒன் சைட் லவர்ஸ் எப்பயுமே வருத்தப்படுறது பாஸ் இந்த உலகத்திலே ஒன் சைட் லவ் ஒரு அற்புதமான ஃபீலிங்ஸ்
புஷ்பான ஃப்ளவர் நினைச்சீங்களா
here. Students from Sri Venkateshwara College of Paramedical Sciences are requested to come here.
அடி ஒவ்வொரு பொருளும் போன அப்படி நான் ரசிச்சேன் உயிர் கொள்ளுது உனக்கு கண்மணியே ஓ ஒரு ஆயிரம் வானவில்லை ஓ பூவி காட்டுதடி அத சட்டுன்னு நீ மறைச்சா என்ன செய்யக்குள்ள
Sheila is rewriting the track.
Competition. Mr. Sri Krishnan sir
and our college student, Ms. Keertana. Please welcome you all to the stage.
கண்கள் இது நெசமான இல்லையா நிலத்து பெரியலையா கனவிலே நடக்குதா கண்களும் காண்கிறதா காண்கிறதா மொழியிலே தெரிவது தேவதையா தேவதையா தேவதையா. Thank you. அடுத்த சாங்கும் இளையராஜாவோட ஹிட்ஸ் தான்.
Tinder
எவரும் சொல்லாமல உயிரெல்லாம் தேனா பாடுது எதுவும் இல்லாமல மனசெல்லாம் இனிமா இனிக்குது ஓடும் அது ஓடும் இந்த காலம் அது போல வந்து தீண்டு போது என்ன வண்ணமோ மனசுல வந்து தீண்டு போது என்ன வண்ணமோ மனசுல காயும் போது என்ன எண்ணமோ எனக்குல வந்து வந்து போகுதமா என்னமெல்லாம் வண்ணமமா எங்களுக்கு ஏற்றபடி வண்ணமெல்லாம் மாறுமமா உண்மையிலே உலகு என்ன என்ன வண்ணங்கள் என்ன தென்றல் வந்து தீண்டும் போது என்ன வண்ணமோ மனசுல திங்கள் வந்து காயும் போது என்ன வண்ணமோ எனக்குல
மிகுந்த பலமான கரகோஷம் தரலாமேப்பா வளர்க்குதுங்க. Okay, I think the judge is ready with this prizes. So let me call Nagin on stage, please. For teams இருக்கீங்களா? டான்ஸர் டீம்ஸ் இருக்கீங்களா இல்லையா? Very good.
ஃபர்ஸ்ட் ஆஃப் ஆல் எல்லாருக்கும் வணக்கம். எல்லாருக்குமே தமிழ் தெரியும். ஓகே, டான்ஸ் பண்ண எல்லா டீமுக்கும் என்னுடைய வாழ்த்துக்கள். எல்லாருமே சூப்பராக பண்ணாங்க. இது ஏன் சொல்கிறேன் அப்படின்னா, ஸோ எல்லாருடைய லைஃப்மே ஸ்டார்ட் ஆகுது இந்த காலேஜ் லைஃப்பில் தான். ஸோ அதில் நீங்கள் டான்ஸ் பண்ணி அடுத்தடுத்து போகும்போது உங்களுக்கு அது ரொம்ப யூஸ்ஃபுல்லாக இருக்கும். ஸோ அதுக்கு ஃபஸ்ட்டு உங்கள் காலேஜுக்கு தான் நீங்கள் தேங்க்ஸ் பண்ணணும். ஸோ காலேஜுக்கு ரொம்ப நன்றி. ஸோ நிறைய பேர் இந்த மாதிரி நீங்கள் ப்ராக்டிஸ் பண்ணி இன்னும் ஹெவியாக பண்ணிங்க அப்படின்னா நிறைய லைஃப்பில் மேலே போகலாம். ஓகே, தென் சோலோவில் ஃபஸ்ட்டு ரன்னர் ஹேனாத் கெவின் குமார். winner Jaineshwari. Now group dance. Group dance என்னோட பெர்ஃபார்மன்ஸ் எனக்கு ரொம்ப பிடிச்சிருச்சு. அதுல எக்ஸாக்ட்டா ஒரு வாய் நல்லா ஆடிருந்தாங்க. எக்ஸல் இன்ஸ்டிடியூட் சொல்லுங்க. வாய் நேம் என்னன்னு தெரியல. செகண்ட் ரன்னர் Again, one more second runner-up, Sri Ramachandra Medical College.
And the first prize goes to
Divine
5-10 minutes. So I'd like to invite two important delegates from the Society of Indian Radiographers Association. Okay, Mr. Shanmugam sir, chairperson and secretary, Dr. Kamji Selvan, who is also an associate professor from Government Paramedical College. Okay, so without wasting much of the time, I hand over the mic to Jayprada for announcing the results. Jayprada, can you announce the results? Okay, meanwhile, can anyone give the feedback in the function evidence and all which are just few words, 1 or 2. Can anyone give the feedback? Yes. Okay, even before that, for the academicians, whoever wrote the abstract, competition academic, e-posters, oral presentations, okay? So, only for good news. Sure? Ready? உங்க கூட parallel work பண்ணி உங்க work கஷ்டப்பட்டு முயற்சி பண்ணி ஒரு மேக்ஸிமம் பப்ளிஷ் பண்ணிட்டேன். இம்பார்ட்டன்ஸ் புரியல, சீரியஸ்னஸ் புரியல. உங்க work பப்ளிஷ் பண்ணிருக்கேன். நீங்க பப்ளிஷ் பண்ணும்போது அது கஷ்டம் என்னன்னு தெரியும். அத்தனை பேரோட ஒர்க்கை அரௌண்ட் 98 நினைக்கிறேன் பப்ளிக் 98% ஆர் given the abstracts. ஏகப்பட்ட கரெக்ஷன்ஸ் முடிஞ்சளவு நாங்களே பண்ணோம், முடிஞ்சளவு உங்கள் சீனியர்ஸை கேட்டோம், உங்கள் இன்சார்ஜை கேட்டோம். ஓகே, ஸோ அவர் இன்ஸ்டியூட் இஸ் ரிலீசிங் மேகசின், ஓகே, ஜேஎன் விட்டன்பேர், ஜேர்னல் ஆஃப் மல்டிடிசிப்ளினரி ஹெல்த் அண்ட் இன்னோவேட்டிவ் டெக்னாலஜி. ஃபர்ஸ்ட் இஷ்யூ இன்னும் 2 மணி நேரம் தான் ரிலீஸ் ஆக போகுது. அதுக்கு முன்னாலேயே ஐ எம் ரிலீசிங் an online version of special edition. Okay, it is called Proceedings of the International Conference SCC Members HCON 2K25. Publisher யாருன்னு பார்த்தீங்கன்னா Walters Kluwer. நல்லா படிக்கிற பசங்க தெரிஞ்சிருக்கும். Medno Publications, Walters Kluwer இன்டர்நேஷனல் புக் சீரிஸ் கொடுக்குறாங்க. லிப்பின்கார்ட் பயோகெமிஸ்ட்ரி பற்றி கேள்விப்பட்டிருக்கீங்களா? லிப்பின்கார்ட் சீரிஸ். ஸோ அதெல்லாம் பார்த்தீங்கன்னா Walters Kluwer பப்ளிகேஷனோடது. Okay, let us see the cover page. Are you ready, Shiva? Yes. இது இல்லைப்பா, next one. முடிஞ்ச ஒரு மியூசிக் போட. It's a very proud moment for all of us. So this is how it's going to be. Proceedings of the International Conference SPCPMS AHCON 2K25 August 2025. Very soon we will get the ISBN number and the DOI number also. நாளைக்கு உங்க பேரை வெப்சைட்ல தட்டா இதுல காட்டும். நல்லா இருக்கா? ஓகே, அதோட கண்டென்ட் கீழே போகுது. நெக்ஸ்ட் கண்டென்ட். Just scroll to the pages.
Okay, now we have the prize distribution for faculty oral presentation. So we have 2 runners. The second runner is Ms. Kamila G, Department of Biochemistry, Scholar, JIPMER. If she is not available, I request the faculty or the student of the college to collect the memento. SBB College, if anyone available. Next we have student e-poster, and we have two runners. Second runner goes to Vishruti, BSc Clinical Nutrition, SBB. Vishruti, Mahatma College, Vishruti from Mahatma College. Okay, next we have first runner, Vinnarasan M. Accident and Emergency Care Technology, SPCBMS. And the winner of e-poster presentation is Sneha Achu Sabu, BSc MRN second year, PIMS College. And next we have a cake cutting ceremony.
I request all the staff of SCC to come on the stage, please. I know staff na another. Thank you.